oral or a remote access approach, in those patients, the main area of fixation was the central triangle. So they had divided the area of fixation into central triangle, peripheral face, and neck. So in most of the patients or normal population, the area of fixation is central triangle. But we can see over here, the patients who have this kind of incision, the viewer's fixation goes towards the central triangle as well as the neck. And this kind of brings a social consciousness in the patient, social embarrassment in the patient, especially for those patients who have a long and good survival. We know about that early T1, T2 lesions, they are going to have good survival. So we have to be really cautious about these patients. We should definitely try to give them a good cosmetic outcome. So technology comes to our aid. Remote access neck dissection has marvelously changed the cosmetic outcome without compromising on the oncological quality. It has been possible because of both robot and endoscope. Robot definitely has multiple advantages. We can see the robot has got multiple arms. We have the advantage of an improved dexterity. We have the advantage of 3D maneuvering. We have the advantage of 3D visualization. We have the advantage of eliminating any kind of physiological tremors. And the best part about a robot is that we can access even the deeper areas of the oral cavity, which usually with our bare human hands, it's very difficult to do that. Multiple robotic approaches have been just explained, transaxillary, bilateral breast axillary approach, then suprasternal approach, and now there has been an evolution towards the retroauricular approach because it kind of gives an access to neck, lateral neck especially, without going for much dissection of the skin and the normal tissue. We'll just go through a brief review of the evolution of robotic neck dissection. So robotic neck dissection, it kind of started with total thyroidectomies, where in the central compartment neck dissection was kind of required, say early T1, T2 tumors of thyroid. But gradually they tried to expand the forte of robotic neck dissection, and they realized that many papillary cancer tumors, they were having lateral neck metastasis also, and from there in the concept and trial of doing lateral neck dissections in head and neck cancers came in. Kang et al. Was one of the pioneers who described transaxillary robotic neck dissection. Gradually it moved towards facelift incisions, combined facelift, transaxillary, retroauricular. Now there are multiple approaches which are kind of in practice. Now we are gradually moving towards natural orifice, endoscopic thyroidectomies and neck dissections as well. Eventually what people realize that going as near to the site of the surgery and going in as much hidden area, that would be the best that will give the best outcome to the patient. And based on this, now kind of retroauricular robotic neck dissection is becoming a standard practice in oncology. Robotic retroauricular dissection was first published by Ko et al. In 2012, and then multiple other publications came from the same university in Korea, Yonsei University, and they are known for their pioneering work in retroauricular neck dissection or robotic surgeries. Though their initial experience, it showed that there was clear cosmetic advantage, and they showed that they were not compromising with the oncological outcomes. So their nodal yield was good. The patient's follow-up showed that there was no recurrence, which was, the data was not very different from what was from conventional neck dissection. So they described retroauricular approaches going behind the standard retroauricular approach, or the coming on from the modified facelift approach. They described it. So there is an advantage of retroauricular neck dissection over other approaches. I am so much emphasizing on retroauricular neck dissection because retroauricular neck dissection is one approach which can be done with robot or without robot as well. It provides an access using endoscope or with naked visualization also it can be done, and hence it is able to reduce the cost of surgery to a very large extent. There are the advantages of robotic retroauricular regression. There is a completely hidden scar. It goes in behind in the posterior hairline. It is absolutely not visible to naked eye. So there is no visual fixation of the observer on the patient for retroauricular scars. There is possibility and feasibility of intraoperative palpation. We can use our hands to palpate if we are suspicious that any node looks like malignant. We can take a decision to proceed in a graded manner, and the surgeon actually has a closer access to the critical structures. So even if there is some mishappening or some trauma to the vessel, it can be very well managed with retroauricular approach without giving any extended incisions, even with proper human eye visualization and not using any endoscope. So that from therein came the next progression from robotic to endoscopic assisted neck dissection. For the robot, the clear disadvantage is penetration into society. The lower strata of the society does not have access to a robot. We know there are states in our country which do not have any single robot. So for a robot, the cost of infrastructure, training, learning curve, everything becomes an issue right now in present scenario in our country. By contrast, endoscope, every NT surgeon is very, very, very well versed with use of the endoscope. And they are actually exploring the areas which is far more critical, skull base and cribriform plate. There are much more critical structures than what neck offers. So similarly, there was evolution of endoscopic assisted neck dissection also, but the first endoscopic neck dissection retroauricular approach was described by Bayon et al. In 2014, and in his seminal paper, he did neck dissection in all the patients were early stage tumors, either glossectomies or parotidectomies. Only one patient was done by modified facelift approach, and the primary approach was by modified facelift. Rest all were transoral, and the approach of neck dissection was retroauricular and modified facelift in most of the patients. So this is kind of an intraoperative photograph of retroauricular neck dissection. We can see how we can preserve greater auricular nerve, we can preserve external jugular vein, we can preserve even marginal mandibular nerve, we can identify all the good structures. We have the advantage of palpating it. The only problem which we can say is a problem is the accessibility of level 1A. So there have been recent evolution in that area also. We'll discuss it ahead. So Bayon's paper, what he showed, this was a very interesting finding, that the total operative time for the first case was around 185 minutes. But as the experience grew, the operative time came down to 123 minutes on an average. While for a normal open neck dissection, the operative time is somewhere around, say, 50 minutes to 60 minutes, 45 to 60 minutes. So this was the main finding, that okay, surgical time is little bit on the higher side, but the total retrieval of lymph nodes, it was not compromised. So it was a very, very important finding that there was no compromise on the oncological safety of the patients. Plus the perioperative complications. The complications were also not that high in the retroauricular approach patients. I'll just show you one poster pic of a patient which we had done. We can very well say how his marginal nerve has been beautifully preserved, his smile is preserved, and the patient's scar is so far behind it is absolutely not visible. As a very young patient, as an army man, he was really very conscious about his scar. He kept on telling his idhar nishan nahi aana chahiye, and that is why we offered this to him. So usually we offer retroauricular to those patients who want to get it done, who do not want scars. He was not even married at that time. And these patients who have a good survival outcome, possibility of a good survival outcome, it is very important to at least give them an option of retroauricular or kind of a scarless surgery. Now, as we were discussing the problem of access to 1A, so here in the the role of using endoscope comes. Endoscope helps wonderfully in the visualization of level 1A area. Even without endoscope, it can be done. We can use it with headlight also. But then, many a times, there can be a problem with the access of the tip region of the level 1A. Here, in that, for that, endoscope helps wonderfully. But if you do not have an access to endoscope, say in some peripheral center, you're going to do some neck dissection and doing a surgery over there, and the surgeon over there does not have an endoscope, we have the option of going transoral and retroauricular combined approach. By transoral approach, we can do level 1A dissection beautifully. You can see both the digastrics over here. And by retroauricular approach, we can beautifully access level 1B, 2, 3, 4, 5. So we do not actually need to give any scar to the patient. Even reconstruction can be done. Free flap recon can be done with retroauricular approaches if the vessels have been preserved beautifully. There are now emerging evidence actually which have kind of established the role of retroauricular approach and the safety of retroauricular approach in oncology. This was a very highly quoted paper about this approach, wherein they analyzed almost around 13-14 papers, and what their main outcome was that the only thing which significantly differs as a downside over conventional surgery is operative time, but with experience it can be reduced. And the cosmetic outcome, the difference in cosmetic outcome is just wonderful. It's marvelous. And patients, they are opting for retroauricular or cosmetic surgeries, even oncology patients, if it is feasible for them. This is also a very interesting paper recently published. They took our paper, the paper published from our institute by Pawar et al., also in their meta-analysis, and their finding was also very similar to the previous paper. This paper was published in 2022 about endoscopic assisted versus conventional neck dissection. We can see they are emphasizing on endoscope assisted. This endoscope assisted term is very important. It means that I'll again emphasize, we do not always need endoscope to do retroauricular neck dissection. It can be done by naked eye also. That is why it is called endoscope assisted and not endoscopic neck dissection. We can do level 2, 3, sorry, 2 minutes more, ma'am. 2 through 5. Just 2 minutes, finishing off. So their outcome was similar, that endoscopic neck dissection, endoscope assisted neck dissection did not have any much significant oncological difference, and they had just significantly lengthened operative time, nothing more than that. So there's a definite consensus in the literature about the indications and contraindications for retroauricular neck dissection. So message should be very clear about it, that which are the cases which are to be selected. The patient should be treatment naive. It should be a biopsy proven early stage T1, T2 oral cancers. The primary should be dissected per orally. You should not require to violate the neck for accessing the primary. And it should be clinically N0 neck. If it is pathologically, so it's clinically N plus, better avoid, because we do not have evidence per se to support it and its oncological safety right now. There are definite contraindications: past history of chemoradiation, recurrent cases, CN plus, if primary dissection requires a skin excision or cervical access, or any history of neck surgery in the past. So this retroauricular neck dissection definitely gives an improved cosmetic outcome, and infrastructure and expertise are required, but can be done. There's definitely a little bit longer duration of surgery, but if we choose our patients judiciously and use a proper technique, and we team up with our colleagues, the future is really bright, and a good, very good cosmetic surgery is every patient's right. Every patient has a right and should be given the choice of getting a beautiful neck like this. Thank you so much for your time, and thank you so much for allowing me to speak. Thank you so much.
Hello.
Hello. Not working. Both the mics are not working.
My part. The body is over, and this is not working. I don't know.
Anyway, talk like that without mic.
You and
Ravi, I like to, you have explained so much of very clearly. I don't need to say much about to add more and more because the time is running very short. So, but I like to convey a message to you is that yes, you can be changed from human hands to robotic, but I like to convey to all of you, especially for my junior colleagues, that the cost price is very high. So every institution, especially I belong from the proper Imphal, Manipur state, and it is very difficult. So I like to once again thank you so much to you, Ravi Shankar, and I keep on hope that the cost also should think of it.
Actually,
okay, thank you so much.
Thank you,
Isn't it, sir?
Actually, ma'am, this surgery, retroauricular neck dissection, we are able to do it at the.
Dr. Sunil Deshmukh sir here with us. Is he here? Okay, then this will be our last talk.
Very good morning to everybody. Good morning to the chairperson. And I would like to give you a warm good morning to everybody. I am Dr. Anurag Srivastava from Aurobindo Medical College, PGI, and I'm working as a consultant there also in Indore. So I'll be talking about a very interesting topic. It's hanging actually. Coming to the introduction, rhinosinusitis, we know it's defined as a symptomatic inflammation of paranasal sinuses and nasal cavity as described by Benninger et al. Etiology composes of systemic local factors and environmental factors. And the systemic factors include the cystic fibrosis and the autoimmune diseases, and the idiopathic consists of Samter's triad and acid reflux. Local factors, we all know that it includes iatrogenic as well as the previous surgery, scarring. And possible environmental factors, that is the focus of the talk, is the presence of biofilms. And this includes the bacterial and fungal infections. Last 15 years, we have seen increased evidence implicated in the presence of biofilms in more than 65% of cases. That is critical to the pathophysiology of sinusitis. So better understanding of the biofilm formation function is very important. That is pivotal in the treatment and defining the novel treatments for the therapy. And this will redefine the sinus treatment paradigm. And so what is a biofilm anyways? It is can exist in a planktonic form, and it leads to form of the microcolonies, and that is the preferred state in which the estimated 99% of bacteria do exist. They are practically everywhere in hot springs, rivers, on the prosthetic devices, or on the plaque. So, so the development of the biofilm it's a very complex process. It's a sessile planktonic bacteria that adhere and form microcolonies, and finally, by the adhesion, they form the extracellular matrix they secrete. That is the protector of the biofilms. This is a very complex situation, because then this extracellular matrix, it is responsible for many other actions. It leads to the antimicrobial resistance by manifestation of the physical barrier. It encapsulates the biofilm as an outer slime layer, and it negatively charged components are repelled also. The antibiotics gets repelled. So the pathophysiology is very important, because the bacteria, fungi, and viruses, both they exist in a symbiotic pattern that augments the survival of the biofilms. And that early research has already given us evidence that there is enough destruction of the architectural pattern of the cilia and reduced ciliary beat frequencies that leads to the complex problems of the situation. And this biofilm is a major barrier in the wound healing, leads to poor penetration of the topical agents. And there is a formation cycle of the biofilm that leads from the planktonic form to attachments and proliferation to a microcolony, leading to formation of the mature biofilm. So the implications, clinically it's a key modulator for the refractory nature of the sinusitis. It is leading to the recalcitrant effect of the sinusitis even after surgeries. It is leading to worse sinus symptoms in objectively validated instruments also, we see that. So, So detection, is it practically possible? No. How can we detect biofilms? It's whether electron microscopy, whether scanning electron microscopy, H&E staining techniques. They are not available everywhere, and the time is also very limited. The patients are in a hurry always. So we have to give them a we want a quick solution for them. So failure, how do I know my patient has a biofilm? By clinical interactions. So there is a failure of maximal medical therapy even after surgery. Most studies, they do say that they have 60% biofilm positivity in the cases. Even osteitis has been related with the biofilms. There is strong correlation with the grade of osteitis by CT and pathological evaluation of the CRS patients. The scoring less than 3 to 5, and more than 5 mm osteitic involvement in the CT scans has been proven to involve because of the biofilms. So how to handle this menace? There are various eradication strategies leading to antimicrobial neutralization, dispersion of existing biofilms, disruption techniques of disruption of quorum sensing has been found. Microlights, even topical antibiotics have been a subject of debate now. And extracellular matrix also protects the bacteria within the host. So we have to tackle the extracellular matrix also. So dispersion of existing biofilm is another thing that is the very important, pertinent topic. Hypertonic saline nasal sprays are coming into picture. These days, enough of Neti talk, and yesterday also there was a talk regarding the biofilms. So antibiotics don't work. How to handle nasal steroids? They are also not very effective sometimes because the delivery is not proper. We were talking about the delivery. So physical disruption by reducing of biomass, improving mucociliary action, improving penetration of the topical treatments. So what is the solution? Identify common characteristic for the growth of resistance that is there. So irrigation techniques are coming into picture. Saline irrigations by the disruption techniques have been found to give some improvement to the CRS symptom scores, and that is by the mucolytic and disruption technique. Traditionally, medical and surgical therapies may not have been effective in long-term sinusitis, but powered endoscopic irrigation, that is known as the hydrodebridement. There is a new technique that is come into picture that is very important, that is the talk focus here. So what is the concept? It is a rotating spray of pressurized saline that delivers 5 ml per second in enabling access to all the sinuses mostly, and for direct sinus irrigation and fluid removal. The powered sinus irrigation is effective in OPD setup also, and rotating sprays, they delivers direct irrigation, suction also same time is available for the sinuses. So we did a small study. There was to study the efficacy and tolerability of the procedure, to see the benefits of the SNOT-22 instrument from the mean average. So the material methods were the inclusion criteria was resistant and recurrence cases, the advanced age, bleeding disorders, coagulopathies, those who cannot go for surgeries, preferred cases for less extensive involvement we preferred. Active infection, active nasal bleed cases were excluded always. So total cases around 31 was covered, and consented patients were enrolled for and recorded at SNOT-22 was recorded at the time of enrollment, and the first session was given, and after second session was given at the interval of 4 weeks, and then the recording was done for total from the first enrollment to the 6 weeks. So total, it was a prospective type study, still ongoing study, and it started in September 2019. This is the SNOT scoring we all know about. SNOT-22 scoring was taken. The 22 factors were counted upon. So this is coming to the instrumentation. This is the console we can see, and there's a saline that is attached to it, and there is the gun or the wand we hold, and that controls the angulation of the tip as well as the delivery of the saline inside the sinuses. We generally do in the OPD setup, and sometimes we can take in the minor OT as well. This is the office setup. This we can see. So this is the biofilm on endoscopy that was seen. So if you can see, the technique goes like that. We deliver first on the jet of spray on the floor of the nasal cavity, then we target to the medial to the middle turbinate, then gradually it is targeted towards the middle meatus area and the frontal recess area. The concept is simple. It is endoscopic guided, powered technique, and it is focusing on the sinuses, and it is respecting the physiology, because we know, so if the drainage is there, then definitely there will be biofilms dispersion will be there, and that will hasten and act as an adjunct for the further treatment. So the results were significant improvement in the SNOT-22 score was noted, And leading three symptoms, nasal blockage, congestion, and altered smell were improved. Thick nasal discharge and post-nasal discharge was also improved. The total SNOT 22 scoring came out of 16 out of 22 improved significantly. These are the improvements that was noted, mainly nasal blockage, need to blow, altered smell. After 6 weeks, lesser of patients reported these problems. The results, the male patients were 17 and 14 of these, 2 were operated cases also. Coming to the discussion part, bacterial infections in the form of adherent biofilms are frequently implicated in pathogenesis and recalcitration. So powered irrigation suction devices have been developed already, and specifically it helps to remove the biofilms. And it is a well-tolerated procedure in the outpatient and in the OT, and it is shown to be have an effective anti-biofilm activity. The leading 3 symptoms were nasal blockage, altered smell, and need to blow nose that improved, and overall scores also improved. Limitations was that it is a small sample size in between. The COVID came, we went for the COVID protocol. Then we are still ongoing now. Single center study, and recalcitrant nature of biofilms is also a limitation of the study. So the take-home message is the hydrodebride system, when combined with saline, may be a useful treatment adjunct for mucosal biofilms. It is very effective tool in pre-op, intra-op, and post-op setup uniquely. It can be established in the OPD setup effectively. It is inexpensive and value for money. It is mostly non-invasive, and it is easy to learn with reproducible results. These were the references, and the motto should be cleaner sinuses and cleaner cities. These are my affiliations. Thank you very much for your cost. The credit cost, they gave me in 10.5 inclusive of the hydrodebrider system. Yes.
Who will be assisted by Dr. Kamini Chavan ma'am and Dr. Anjali Gupta ma'am.
But sirs amongst us, ab sir sab kar denge. So all the PG residents who are standing outside, we consider your train and flight timings. Please come inside. Please come inside.
The PG quiz. Yesterday, we had a lot of good performances from the PGs. We had a preliminary round wherein 29 teams participated, and the 4 teams qualified for the next round. And the guys were amazing, superb. No words to compliment them. They are really, intelligent, super, what you say is less than describe what you can. And for this round, this is an important one, wherein 4 teams are there for the final round. And for this, we have a special jury member amongst us, Dr. Santdeep Pon. Can you come forward, please? For everybody, Dr. Santdeep Pon, you have seen him in action on Thursday, on the day 1, on the live surgery workshop. He is one of the most sought after rhinoplasty surgeon in the world. He's a dear friend. He practices in London. He's a celebrity rhinoplasty surgeon, operating on many celebrities. And moreover, he's a great teacher. The way he teaches is simply mesmerizing. And we Jaipur guys are especially blessed, as he has been visiting Jaipur every year for 5 to 7 days to teach hands-on. That's the only course in the world where the rhinoplasty teaching is going on hands-on, and solely because of him. Thank you, Dr. Santdeep, for again being with us and teaching us and making us more and more wiser every time. Look, कहाँ रह गए यार? Of the quiz yesterday, You and your is coming. So sitting arrangement sitting arrangement karo. Dupilumab is a monoclonal antibody. Yes.
अभी हमारे बीच में कितने पीजी
Then from the organizing committee of the team Aoicon, from the organizing secretary Dr. Tarun Oza, who has announced a big award for the winners, for both the team members who are going to win the quiz. Apple Watch will be awarded to both of them. And for the runners-up, their registration fee will be returned. And there are many more, prizes which are going to have many more exciting and interesting prizes for the audience. So let's begin with the first question, as we are already running behind the schedule. So can you please connect? Team A, this goes to Team A. Take your time, discuss together and then answer. Yeah, there are no
Which part
negative
of cochlea is closest to the labyrinthine portion of the facial nerve? Your option is option A, ascending basal turn, option B, descending basal turn, option C, middle turn, option D, apical turn. Which part of cochlea
Take time.
is
Yeah.
closest to labyrinthine
You will
portion?
not be given a second chance once you answer anything. So discuss together. So labyrinthine portion of the facial nerve is in discussion, and which part of all of these are all four options are the parts of the cochlea, and which of them is in closest proximity to the labyrinthine segment. Middle turn, lock कर दे. Okay, middle turn. So middle turn is a wrong answer. This question I purposely kept as we discussed on the day of the live surgery during cochlear implantation. The answer was given there. The ascending basal turn of the cochlea is in closest proximity to the labyrinthine segment. And that's how this is relevant in patients who are having autosclerosis. This part of the bone may be dehiscent, or in autosclerosis, this part of the bone is hypodense. So this can get stimulated. So unfortunately, your answer is wrong to begin with, but still you have a chance to answer another question. You told middle turn. For middle turn cochleostomy, and you lost 5 marks, still you have a chance to gain 5 marks. This middle turn you mentioned, if you are doing a middle turn cochleostomy, what is the best landmark you will take into account? If you are given a chance to do a middle turn cochleostomy, what is the best landmark you take into consideration? Sir? Okay, for apical turn, one more chance. I really want to give. For apical turn, what is the best landmark you can consider during apical turn cochleostomy? There is no negative marking. Still both questions are existing. Which is the best landmark for the middle turn, apical, anything you'll get 5 marks straight away. Last 10 seconds. तुक्का ही मार दो. No negative marking. Huh? Saccule. Well, identifying saccule is much more difficult than the apical turn, I believe. So your answer is again wrong. So from the audience, what is the best landmark for the middle turn? Raise your hands. There is negative marking for the audience also. But you'll be rewarded if you get a correct answer. For middle turn cochleus knee, what landmark would you take into consideration? Is close to. Anything you want to add on? IS joint. They're more far off than what he has reached. Yes?
Sir, is it traditional standing?
That is for labyrinthine segment of the facial nerve. I am not talking about the middle tongue cochleus knee.
Is it posterior?
No. So he is close to it. You have to stay anterior to the oval window, just underneath the processus cochlea. You drill over there, you will reach directly to the middle tongue where the ascending basal tongue is turning to the middle tongue. So you are close to it. You are the only one close to it, you get something. So now we go to the. It is not transferable.
For team B now.
Yeah. So team B now.
So question for the team B, which of the following structures does not show indentation into the cavity of the well-pneumatized sphenoid sinus? Option A, vertical cavernous segment of the carotid artery. Option B, V2. Option 3, V3. Option 4, median nerve.
So in the simplest way, which of these structures doesn't show up in the pneumatized sphenoid sinus once you see with the endoscope? There is nowhere you see with the endoscope one of these structures in the sphenoid sinus. Rest three are visible. You put your endoscope in a well pneumatized sinus, you can see, but one is never visible. V3, lock? Sure? Both? Correct answer is V3. So V3 is the correct answer. Even in the most well pneumatized sinuses, V3 doesn't turn up because V3 is far up coming from the foramen ovale. Vertical cavernous segment is there, always there. So you have got 5 marks, but you have one more chance to earn 5 marks. What are the different segments of the cavernous segments of the carotid artery? Cavernous segment, different parts. As it comes into the sphenoid sinus, foramen lacerum, it ascends to become the cavernous carotid. And cavernous has a tortuous course. What are the different segments? You get 5 marks straight away. If no, I can ask another thing. Still you get the 5 marks. Any branch of the cavernous segment of the carotid artery, you enumerate. Any branch. Carotid artery doesn't give any branch in the neck. It gives in the cavernous segment. No negative marking. Median artery still have a chance. Now not about the branches, about the segments of the carotid, cavernous segments. The chance of telling a correct answer for the branch is gone. Median artery doesn't arise from the cavernous segment. Okay. So the question goes to the audience. As the cavernous carotid starts, it has a tortuous course. Which are the different parts of the cavernous carotid? In order. From foramen lacerum, it ascends to become cavernous carotid. Now, first, I have already told you the ascending part. We call it paraclival. Then, yes?
So then it takes a backward turn. And then
Yes,
becomes
posterior
horizontal-
band. Yes,
Then becomes a horizontal cavernous.
yes.
And after that, then it ascends along the clinoid process to become the
Super, super duper. You have been hand your name
Dr. Udasha Bakidar,
from?
IPGMA and SSKM Hospital, Kolkata.
Super. So cavernous has three parts as it ascends as a vertical part, paraclival, then a posterior band, horizontal, and then anterior band. Now branches, anybody? Raise your hand first. Tell me if you are fully sure. Wrong answer will debar you from participating in next question. Yes. Meningohypophyseal, yes, and inferolateral. Can you tell me where the meningohypophyseal arises from? Your question is right. Here's the correct answer. You deserve this. So from the horizontal band is the inferolateral trunk, and from the posterior band is the meningohypophyseal trunk, which gives three branches. Superb. So the team B gets 5 marks, I suppose, huh?
Yes, sir.
So third question.
So
to the
next
team
question for the team C. Which of the following is not the good landmark for the parapharyngeal carotid artery? Your option A is eustachian tube, option B mandibular nerve, option C median nerve, and option D tensor palatini muscle.
Parapharyngeal, every segment of the carotid artery has some good landmarks. So which one is not good for the parapharyngeal? 3 are good. 3 can be used as a good landmark for the parapharyngeal carotid, except one. If you remember, I had given answer yesterday in the quiz. I have given you a clue. Final? So correct answer is median nerve. You get full 5 marks. So median nerve is responsible. You get another 5 marks if you give correct answer. Median nerve is responsible for postganglionic fibers or preganglionic fibers for the secretion of which gland? Secretomotor fibers. Sure? Full 10 marks. Lacrimal gland is the correct answer. As the median nerve is formed at the foramen lacerum, it comes to the pterygopalatine ganglion and it leaves secretomotor fibers for the lacrimal gland. So I had given this answer yesterday in the quiz and you utilized that opportunity. Great. So we move on to the next question to the team D.
Which of the following cochlear anomaly is associated with least incidence of CSF gusher? Your option is IP1, your option B is IP2, option C IP3, option D common cavity malformation.
Least chances of CSF gusher. I can give you a clue which is a more developed cochlea out of all these. वन श्योर उससे पूछ पक्का वेरी श्योर So wrong answer, IP1. IP1 is the wrong answer. Correct answer from the audience. Raise your hand. Priyanshi. You? Your name? Wrong answer.
अभी बोल रहे अभी क्या बचा है ये देखो
See, IP2 is associated with Montanese deformity. It is just like a normal cochlea. So IP2 is the right answer. Rest are least differentiated. So the correct answer was IP2. And now is the time, very important question for the audience. Listen to this, and there is a big prize for this answer, correct answer. And the big prize comes from Dr. Mubarak Khan. Yes?
Yeah.
The correct answer, who gives the correct answer, will get a
You
just
have
attached from Dr. Mubarak Khan worth 40,000. So think twice before answering.
Which of the following cochlear anomaly is associated with highest incidence of meningitis?
This is for audience.
Option
Think
A,
twice.
IP1.
You need to have explanation for the answer. So kani chalega. Please. So the just take. See, all these are responsible. You have seen in the last slide. That's why I put up in the next. All these things, all these anomalies can give meningitis. Which has the highest possibility of giving meningitis?
Fourth. Fourth, sir.
Anybody? Common cavity, common cavity, common. IP1.
सर मैं भी
Give me back. Anomalies are all with all. The reason is which is the highest incidence of meningitis. This has a huge clinical implication. That's why I put up this question. So IP3. Anybody? Why? Once somebody told IP3, somebody told IP2, somebody told common cavity, now IP1 is left. Any reason behind it? Huh? Fundus? No. Fundus is more defective in common cavity and IP1. Fundus is defective in IP3 also. IP3 has a very high chance of pressure. All these have a chance of pressure. At least with IP2 we have discussed. More chances with IP3. Okay, the more chances of gusher, highest chances of gusher are with IP3, but still the least chance of meningitis.
Oh. So it is within.
Common cavity because you are exposing.
The cochlear duct is in the common cavity itself, so the chances of meningitis are high.
So, again, don't Google. So, who said IP1? Sir, अभी तो common cavity बोल रहे थे आप. You made a team. He said different, you said different. So, correct answer is IP1. Anybody, any reason behind this? There's a huge impact. Whether you do an implant or not is a different thing. This deformity itself has the highest chance of giving meningitis. Because IP1 is associated with an endosteal anomaly, where the foot plate is deficient and the fluid sac is bulging from the foot plate. It can get infected any time the patient gets otitis media, can get infected and develop meningitis. Because it is directly in communication with the subarachnoid space. So IP1 is anomaly. Even if you do implant or not, it has a highest chance of giving meningitis. Any point of time the patient acquires otitis media can develop meningitis. So IP1 patient, if you see, at least advise in surgery a subtotal pedotectomy application to prevent meningitis, whether you operate or not, whether you do a cochlear implant or not. So IP1 has a huge clinical impact, and all these three, IP1 has a direct communication with the subarachnoid space. Okay, you still have a chance. Just attach. Out of this, which is the rarest anomaly? Just attach. Three. Anybody? One.
Three because it is well developed. That may be the reason. Three is because it is well developed. So, but not sure.
What is the other name of IP3? IP3 is a common name. IP3 is an uncommon name. The X-linked Gusher syndrome is IP3. IP3 is X-linked Gusher syndrome. It has a genetic abnormality which is very, very rare. So IP3 is the rarest of all these abnormalities. Still have a chance. Out of these anomalies, in which anomaly there is earliest arrest during embryonic period for the development giving rise to this anomaly? Earliest. You know, the inner ear start developing from 3rd week of the fetus and mature by 25th week. And all these malformations occur when the developmental arrest happens. So at which one of all these, when the earliest developmental arrest happens to give that anomaly?
Common cavity. Common cavity.
Who said common cavity?
Sir.
Common cavity.
Sure.
Yes.
Which week?
So 5th to 6th week.
Anybody?
4th week.
Anybody?
4th week. So 4th week.
4th week, anybody?
The 3rd week.
Your good name? Tom? Tom James Jodhpur Nitika deserve the just attach. It is the 4th week. The earliest of all these where this cochlear development, cochleovestibular development, inner ear development arrest at the 4th week leads to this deformity of IPL, the common cavity. Congratulations. Congratulations. And thank you, Dr. Mubarak Khan. So in developmental or developed. So our first round is over.
Sir, you need to ask add-on question. You have asked everyone, even the first.
Your add-on question was not asked?
No.
Oh,
No.
I'm really sorry. Why didn't you tell me that time only? Your second question was left, no? Okay. This was your question, no?
Yeah.
Okay. Which of these anomalies have associated, highest chance of associated facial nerve abnormality? One more chance I will give you. No? Which anomaly has a, I told you IP1 has a, now I am giving you clue as well. IP1 has an endosteal anomaly. Which one of these has periosteal and enchondral anomaly? It is IP3. See why I am asking this. I will discuss all these malformations. IP3 is a malformation known as X-linked pressure. All these have morphologically cochlear outside dimension are same. Internal architectural defects are there. In IP3, the modulus is deficient and the outer cochlea, the bony cochlea, follows the membranous labyrinth. There are three layers of the cochlea, bony cochlea: endosteal, enchondral and periosteal. So enchondral and periosteal layers are left and the cochlear shape is like membranous cochlea. It has a classical shape which is going to come in next question. So I will answer that so you don't get any mark out of that. So next round we start with team A.
So your question is, which of the following nerve truly passes through the cavity of the cavernous sinuses? Option A, ophthalmic nerve. Option B, abducens nerve. Option C, trochlear nerve. Option D, oculomotor nerve.
So one of these nerves pass through the blood of the cavernous sinus. All four are supposed to pass through the cavernous sinus, but one through the blood of the cavernous sinus. I am sure it is not difficult. Sure? So correct answer, abducens nerve passes through the middle of the medial part of the cavernous sinus. Rest all these nerves do not. So the next part of the question is where we say all these nerves pass through the cavernous sinus. So where do these three nerves pass through? Lateral wall. Where lateral wall? Between what layers? Anything? These three nerves do not pass through the blood. So where do they pass through? Hi Manish. Hello.
The dura. They're outside the cavernous, in the lateral wall, is lateral elevation, outside the dura.
Outside the dura. Okay, leave it. Out of these three nerves, which one is the lateral most? Again, you have a chance. Your first part answer was correct, you get 5 marks. This is the second chance for the second part. Correct answer, ophthalmic nerve is the lateral most of all these 4 nerves. So they get total full 10 marks. So these 3 nerves pass in the lateral wall between the meningeal and periosteal layer of dura. Between the dura, not outside dura. That's why your answer was not correct. But out of them, the ophthalmic is the lateral most going to the superior orbital fissure. So this is very important and congratulations, you get full marks.
So next question for the team B. Which of the following nerve pass through the pterygoid process except option A, pharyngeal nerve, option B, maxillary nerve, option C, mandibular nerve, option D, median nerve?
This anatomy is very important in endoscopic surgery. Pterygoid process has so many foramina, so many nerves pass, except one of these. Pterygoid is a part of sphenoid bone. Sphenoid has so many parts. Lesser wing, greater wing, body, pterygoids. Is a very, very complex bone. I have answered this question yesterday. So, after this round will be the clinical round, some video rounds. The time is getting over, dear.
You have 20 seconds left.
10 seconds. You're giving too much.
Option B, maxillary nerve.
Maxillary nerve, option B. इतना सोच समझ के. It's wrong. Maxillary nerve is V2. Okay, you still have a chance to grab 5 marks. You said maxillary nerve. Can you tell all these nerves? Which two are pure sensory nerves? Again, have a chance.
Pharyngeal and maxillary. Pharyngeal and maxillary nerve.
Pharyngeal and maxillary, absolutely correct answer. You get 5 marks. So, for the first part, which now doesn't pass through the pterygoid? Anybody? See, entire house knows. You only answered yesterday the mandibular nerve passes through the foramen ovale, which is a part of greater wing of sphenoid, not the pterygoid. So this question was answered by him only yesterday and he got confused. So the answer is mandibular nerve. Third.
So next question for the team C. Which of the following nerve is responsible for the referred otalgia in oral cavity lesion? Option A, glossopharyngeal nerve. Option B, vagus nerve. Option C, mandibular nerve. Option D, chorda tympani.
For oral cavity lesions. Referred otalgia, lesion in the oral cavity and you feel the pain in the ear. So what is the arc? Which nerve is responsible? At both ends. I've given you a clue.
Ten seconds left.
You always say you have a lesion here in the tooth and you get otalgia.
Sir, mandibular.
Which?
Mandibular.
Sure?
Yes.
So the correct answer is mandibular. The next part is how come? How it is goes to the passing to the ear? How come the oral cavity lesion is giving otalgia in the ear? Your answer is right, mandibular. There is no negative marking. You can try.
The lingual nerve, the lingual nerve is a branch of mandibular nerve which supplies the anterior nerve, and the auriculotemporal nerve.
Amazing. Amazing. Big hands to them. So lingual nerve is a sensory nerve which takes the sensation from the oral cavity, and it is a branch of mandibular nerve. The other branch of the mandibular nerve is the auriculotemporal, which supplies the ear. So you get full marks, and big round of applause for them. Great answer.
So next question for the team D. Leukotrienes are principal mediator in following endotype of the CRS. Option A, AFRS. Option B, AERD. Option C, cystic fibrosis. And option D, non-polypoidal sinusitis, chronic rhinosinusitis.
So let me help you out further with the question. You see, CRS has many endotypes. You can see there. Allergic fungal rhinosinusitis, respiratory disease, cystic fibrosis, and non-polypoidal. Every endotype has a different mediator, different pathophysiology. So leukotrienes are involved in which of them? As simple as that. Aspirin, exaggerated respiratory disease, allergic fungal rhinosinusitis, cystic fibrosis, non-polypoidal. All three are polypoidal, one is non-polypoidal. This has been discussed several times in the presentations day before. Which one? B. Sure? So correct answer is B. Aspirin, exaggerated respiratory disease. So next part of the question is, In which deficient metabolism this kind of a leukotrienes are coming into play? What is the basic pathophysiology? Why leukotrienes have come? Your answer is correct, leukotriene, but why? How come the leukotrienes have come? What is the pathophysiology? Okay, I'll give you another question. You still have a chance. Have you heard of drug xylutine? Any drug to block this pathway? This is very simple now. You said leukotrienes are having the maximum role, principal role. Now which drug can block? Sir? सर ने बोल दिया इसलिए वो गलत हुए तो ल्यूकोट्राइन इनहिबिटर कितना हिंट दिया मैंने स्टिल यू गेट 10 marks. The correct answer is the leukotriene receptor inhibitor. Since leukotrienes are involved, the receptor inhibitor is montelukast. So you were offered 10 questions as a gift, but still not understanding. Sir ने जवाब दे दिया. Anyway, so leukotrienes are involved in AERD. We all know it is a defect in which metabolism? Arachnoid acid metabolism, which preferentially leads to prostaglandin blockage because of the COX hypersensitivity, and lipoxygenase activates, which produces leukotriene. Now, what is xylutine? Xylutine is a drug which can block leukotriene, pathway. The effect of leukotrienes, whatever. Xylutine can block production of leukotriene by blocking lipoxygenase. So xylutine is an important drug. Montelukast is an important drug. So many drugs have a role to play in AERD. Next.
So this next.
Which?
We are done with the 2 rounds. Sir.
We are done with the 2 rounds. So this is an important prize round for the audience.
All the delegates, please note that your certificates are ready. Kindly collect from the registration counter before 2 p.m. The management team is requesting to collect all your certificates before 2 p.m. Secondly, for all the faculty who have not received their memento as a chairperson, please send in your details to us. We will mail you those mementos. We have a delegate group on WhatsApp. You can send your name and the chairperson for which the session you were, and we'll mail you the memento. Thank you.
So there is a prize question for the audience, and it has a big prize. And we are thankful to Dr. No prize. There are so many already. Okay, come up, anybody. Who said gallium? Who said gallium? See the question. Best functional imaging modality. Out of them, all 4 are imaging modalities for malignant leukemia. Which is the best one? There was a girl who was awarded RAF Cooper Award, on malignant otitis media award day before yesterday. This question is why I put up best functional imaging modality, single imaging modality which can diagnose best, through which you can monitor the treatment response, through which you can follow. Single modality which is best for all three. No question will be
अच्छा, PET MRI scan.
Because it gives the circulation and functional.
Sir, I think it's gallium 67. It's a PET MRI.
Sir, PET MRI. Because it is functional and monitor with MRI.
Okay. These two above are what? What functional? These are? There are various types of tracers, you know. Above, the first two are?
First one for first class, second.
What kind of tracer these two are? They are gamma tracers, beta tracers. What kind of tracers these are? Gamma tracers. So you can see the activity. But how will you localize?
PET MRI.
So beta tracer is FDG. And if you combine with a CT or MRI? So correct, sir gets the prize, sir, for the PET MRI. The reason being, FDG is functional. It gives you idea about the functional activity of the infection. But where the activity is going on, you need to locate, and that you can locate to the anatomy around is the PET. Between CT and MRI, why MRI is better? Because
On the
MRI
first
gives
question,
additional soft tissue.
you have answered it wrong.
It gives additional soft tissue information, additional sequences
So
which
this score
CT
is
cannot offer,
10.
and you don't need radiation for that. Additional radiation. So PET MRI is ideal for diagnosis. You get the FDG activity. As you give the treatment and it comes in effect, the activity reduces, you can monitor. And you can follow up better without the need of further radiation with the PET, the MRI. So PET MRI, the investigation is there. Now who said technician? Technician is useful at what point? Diagnosis, because it detects the osteoblastic activity fastest. So out of all these, technician can detect earliest, even before the PET MRI. What is the value of gallium? Did you ever get a gallium scan done? Anybody? Gallium is most expensive of all of these. Highest dose of radiation amongst all of these. Yet it is a good investigation to monitor the treatment response because gallium is active on dividing cells. As the infection starts, the leukocytes start dividing and the gallium start detecting. Very well. You give treatment, antibiotics, the leukocytes comes under control, the gallium activity comes. So it is one of the best to monitor, but you cannot localize. It is beta tracer, but there is no localizing ability. So out of all, if you have a malignant otitis externa, why I put up this question, this is a difficult pathology and the best investigation is PET MRI for every region, every time.
So we will update the score now. We will update the score.
Yeah. Anjali, can you update the score so far after 2 rounds?
Team A, total score after 2 rounds, 5 marks. Team B, you have first question negative,
So
-5.
we have the negative marking of 5.
No negative mark.
No negative?
No negative mark.
Okay, fine.
So they get 10 marks.
Yes, sir.
10 marks for the team B, 10 marks.
Team C,
20 marks.
and Team D, 10 marks.
So team C is leading. Team C is from Maulana Azad. AIMS Rishikesh. Oh, great. Great going. So I am going to AIMS Rishikesh this April for a workshop. So they are a great team. So now question goes to team A again. Now this is the diagnostic round. These 4 scans are showing different kind of fungus. Which one belongs to the non-invasive fungus? All look invasive. Which one is non-invasive?
No, it is for participants.
This is for participants. Please don't describe, don't let us answer. That may be detrimental to the participants. Ten seconds. I had given this answer 3 times in this course. Day 1 in the live surgery, day 2 on the MRI talk, and day 3 yesterday in the CTPNS talk. All 3 times. B, are you sure? Is this non-invasive? So correct answer is D. The team may get full 5 marks. B is non-invasive. Now what kind of non-invasive fungus is this? A part of the question for 5 marks. And second is
AFRS.
AFRS. So what is the treatment of choice for this?
We do surgical removal and then post-op we give inhalational steroids.
Inhalational.
Post-op immediately systemic and then later in follow-up.
Super. So they get full 10 marks. This is allergic fungal sinusitis. For the audience, how it comes? It is so much of bone erosion and it is non-invasive. What is then A? Audience. It is fungal sinusitis, invasive fungal sinusitis. They say this is the only B is non-invasive, rest are invasive. So what kind of invasive fungal sinusitis is A? Which invasive fungal sinusitis is A? Raise your hand. Come on, you have very few options. You can try. What kind of invasive fungal sinusitis is A and what kind of invasive fungal sinusitis is C?
Is it mucor?
Sir, mucor, anybody? Why?
It's limited within the cavity, orbital cavity. It's limited within the orbital cavity, not taking up contrast as such.
Not getting?
Not taking up contrast. So it should be aspergillus.
Okay. The reason is not correct. So this is chronic invasive fungus, aspergillosis. We have been discussing for last 3 days. It is mucor now. Why D is mucor? Anybody? So it is all necrotic. You see the turbinates necrose. See the turbinates not taking. This is a contrast MRI. And on the left side, the turbinates are not enhancing. Necrotic. So this is mucor. The B and A and C are chronic invasive because there is minimal intrasinus disease, bone erosion, and more extrasinus disease. Both the cases it is in the orbit. What is the treatment of choice now? Quick, treatment of choice for A and C. Who said? Fisher. Debridement. Anybody? Huh?
If we can see any necrotic areas, we need to remove that, debride that, followed by medical management.
Followed by?
Medical management with the
What medical management? Correct answer. She has a full correct answer and she gets this definitely. So for chronic invasive fungus, voriconazole is the answer. Next question to team B. These are 4 pictures, you know. We are talking about the cochlear anomalies. A, B, C, D. Name 4 anomalies one by one. You get full 10 marks. No further question. If you give 2 correct answers and 2 wrong, nullified. 2 correct answers, 2 not attempted, 5 marks. Again, I will give you chance for 5 marks. So try. These are 4 anomalies, cochlear anomalies. We have just now discussed. What are these? 2.5 marks for each now.
B common cavity and
B common cavity.
D large vesicular aqueduct.
D.
Yes.
And
AIP type 2.
AIP type 2 and book आई थी ना? Book. So now C is left. Okay, so all four are wrong. Now this question goes to audience, and anybody who says all four answers correct will get a special prize. This book from Monish Grover, who's written on coffee. All four in order should be correct. Anybody raise your hand? The wrong answer will be debarred for next 3 rounds. These are 4 cochlear anomalies we have discussed in detail. What are these 4? A is IP3.
B is cochlear hypoplasia 4.
Cochlear?
Cochlear hypoplasia.
4. Okay.
C is IP2. D is cochlear.
Why it is B is cochlear hypoplasia 4? You are very close to correct answer, very close to get this book. Since you have all 3 correct answers, nobody is there to compete. I give you another chance. What is 2? What is B? Please, your 3 answers are absolutely correct. Another chance for the B. No negative marking, try once something. IP3 is correct. IP2 is correct. Common cavity is correct. Dilated vestibule is a B, and what it could be? Please. Anybody? What is B? इतना बड़ा vestibule, how come hypoplasia? It's already told IP2 is C. So, you come forward, you still deserve this book. Out of 4, 3 are correct. Your good name?
Dr. Anshu Rawat,
From?
SMS Medical College.
SMS Medical College. Why am I not able to answer 4 questions? Okay, why it is IP3?
So there is no modulus.
Epic.
Incomplete partition is there, and IAC is very wide. So cochlear is
Where is IAC? I don't see IAC. Anyway, it is IP3. Why it is IP2?
basal term of the cochlear is and middle and mitral
Super. The B, correct answer for the B is
apical turn है ना.
IP1. IP1 has cochlea has no internal architecture. It looks like a common cavity. Vestibule is dilated. So IP1 has vestibule dilatation and cochlea has no internal architecture and communicating directly with the intra-auditory meatus. But you have 3 correct answer and you so you deserve this book, and I invite Dr. Pamal Singhal, Professor, SMS Medical College, to present this book to Dr.
Anshu.
Dr. Anshu. Superb, well deserving. So the fourth answer is IP1. The B is the IP1. Congratulations. Which, for the audience, again is a prize. The first one is IP3. I told you, see this architecture of the cochlea. It is, the bony outer shell is deficient. Only endosteal membrane is intact. So it is following the architecture of the membranous labyrinth. That is how the picture is like that. The periosteal and enchondral membrane is deficient. IP1, no internal architecture in the cochlea, and the vestibule is dilated. IP2 is the basal turn is normal and the apical and middle coalescent to form a single cavity. And D is common cavity, no architectural differentiation. The cochlea and vestibule together, a common cavity opening into intra-auditory meatus. So, audience question again with a big prize. Which of the following deformities had enlarged vestibular aqueduct? Only one. Raise your hand if you are confirmed. Out of these, only one has enlarged vestibular aqueduct. Sir, wins the prize. C, and this is IP2. That forms a Mondini's deformity with a dilated vestibule and enlarged vestibular aqueduct with IP2 is Mondini's deformity. So, sir wins the correct answer, gives the correct answer and win. So, team B, your all answers are wrong. Now you got to know what are all these. Can you repeat? If you repeat correctly all 4, I'll give you 2.5 marks. Tell A. A is IP3.
B is IP1. C is IP2. And D is common cavity.
Common cavity. You are still wide awake, huh? You get 2.5 marks. Team C. This is, you all know MRI. There are 4 sequences written. MRI is so useful. I covered in detail in day before's course for 1.5 hours about the MRI, the utility of the MRI. 4 sequences, out of them 1 is a contrast, 1 is T1, 1 is diffusion, and 1 is T2. Can you label which all are these? One by one. Please don't utter. Correct answer will take you full 10 marks. 2.5 marks each straight away. Clear cut division. Just identify the sequence, you get the marks. Time is running out for you. At least tell 1, 2, 3 so you get some marks.
C is T2.
Okay.
Sir, C is T2.
C?
Yes, sir.
C is T2.
T2.
Okay.
Sir, D is contrast.
T is contrast.
Yes, sir.
You can.
And
T
sir,
for not T.
and sir, A is T1. B is diffusion.
D is diffusion. No negative marking, so his 2 answers are correct. So he gets 5 marks and no further questions. The correct answer for the A is T1 and C is T2. Audience. Now the question is very clear. What are B and D?
Ask them to raise their hand.
What are? What is B? Anybody? Who says? Everybody. Then what is D? What is D showing? He said diffusion. What is D showing? Is there any positive finding in the D? Anybody? Chocolate is yours. Coordinate law. Come on.
D is contrast.
D is contrast. Anybody? He said contrast and I said wrong. Still you are repeating. So? Huh? Which injury? Axonal injury. My God. So B is contrast. Who said? Who said B is contrast? The B is contrast, it is correct. Why are you why are you so scared? So why B is contrast? What is there in the B to C contrast? Blood vessels are there. So see, the B has blood vessels prominent where the contrast is going. See number of vessels all around. So B is contrast. And D is obviously diffusion now. And what you see there are early infarcts. Diffusion is known for 2 important reasons. See, I say MRI has versatility of giving so many sequences. Every sequence has a value. Number 1 value in diffusion is you can differentiate between benign and malignant tumors. And number 2 is the only sequence which detects infarcts earliest in minutes. If somebody gets a TIA, somebody gets any infarct, diffusion can pick up in 5 minutes. That's why it is such a valuable sequence. So B is contrast, D is diffusions. You get 5 marks. We move on to the move on to the next one. Come on. Okay, you get enough clue. Okay. What investigation is this? What investigation is this? This was already written, so you get next chance to. The question is not started now. What is this showing? Showing some vessel in the head and neck. See this. See what this vessel is coming again and again. See what is happening. DSA's full form is digital subsection angiography. So what is this? Please. This is for the participant. Can you see some vessel? Yes. Internal carotid, DSA, you get 5 marks. Now, what DSA, how do we ascertain cross flow in DSA? that the cross flow is good. Any two methods. Name two methods to get 5 marks.
So one is we can insert a balloon and obliterate the vessel and see it from the contralateral side whether the entire circle of Willis is visible or not. Otherwise, it can be also done with a coil. And even there are absorbable gel forms material which can be...
One side is blocking. Blocking, you block by anything. One answer is correct.
Yes, sir.
Another way. There are many methods on DSA to see whether cross flow is good, because this is so important. If the cross flow is not good and you happen to close the carotid, there will be a disaster. There will be stroke and mortality as well. It has a significant mortality also.
So we can obstruct the
So his answer is correct, that you obliterate one carotid by balloon or anything and see the cross flow coming from there at the circle of Willis. Now, what vessel make the circle of Willis? Again, you have a chance. Full circle of Willis.
Sir, posterior cerebral, basilar artery divides into posterior.
Pardon?
Sir, basilar artery dividing into posterior cerebral artery. Posterior cerebral artery, then middle cerebral from anterior side, and then communicating branch from posterior to middle cerebral.
So one is posterior cerebral, yes.
So then there is communicating branch from posterior cerebral to the middle cerebral and anterior cerebral artery.
Super. So he has answered correctly all the 4 components of circle of Willis. The carotid artery anteriorly gives 2 branches, anterior and middle cerebral. From middle cerebral, the posterior communicating is joining to the posterior cerebral, and that's how the arc is completed. So you get full 10 marks. Congratulations. So now is a big question for the audience. For the big prize, for the correct answer, will get a fellowship with hands-on cochlear implant at Dr. S.P. Dubey's place. So 10 days fellowship with 1 or 2 minimum hands-on cochlear implant. We are grateful to Dr. S.P. Dubey for announcing this prize, and that will definitely help somebody to learn cochlear implantation. So think twice before answering. There are 2 lines, 2 lines in this diagram, red and yellow. See on the right side. There are 2 compartments, one compartment within yellow line, one compartment within the red line. There are different spaces in this region, and many times the terminology is so confusing. Just get a clarity, what are these 2 spaces, yellow and red. I'll give you some more pictures for your understanding. Yellow and red, what are 2 different spaces? One more space blue on the other side. So yellow is a different space, red is a different space, encompassing different structures, bounded by different structure, extent is different. What are these 2 spaces which are overlapping? See, these are overlapping also. These are important for endoscopic surgeons, they are important for the head and neck surgeons. Yes, please. Yes. Okay. Anybody else? Yes? One is masticator. Correct? One is masticator, another is such a big one. It's far lateral to the pharynx. Yes?
So the yellow is the parapharyngeal space.
Down. Yes, yes. It has huge clinical implication. That's why I'm asking. Which one? Anybody?
Satish? Satish.
Yes? You want to answer? Yes, you can also participate in audience question.
Yellow is masticator space.
Yellow is?
Masticator space.
Yellow is masticator space.
And blue is infratemporal fossa.
Which one is?
Red is infratemporal fossa.
And blue is? Okay, these two spaces you answered is absolutely correct. The yellow is the masticator and red is the infratemporal fossa. There is always a confusion which is masticator space, which is infratemporal fossa. Some say both are same, some both are different. Your answer is correct, no doubts. Why? What are the boundaries of these two different spaces? Why you label one is masticator, one is infratemporal? What are the boundaries?
Infratemporal fossa, lateral boundary is the ramus of mandible.
Okay.
And the masticator space involves all the masticatory muscles.
So lateral boundaries?
The masseter.
And medial boundary? Both?
Medial pterygoid.
Both same?
No, masticator space is medial pterygoid, and infratemporal fossa, middle boundary is pterygomaxillary fissure, which continues in the pterygopalatine fossa.
One is correct, the other is not. And posterior boundary, they are close to.
Of
Both these spaces are posteriorly same?
Posterior boundary.
So she has given maximum correct answers. Anybody, what is the difference in posterior boundaries of these two spaces? What is the basic difference in these two spaces? Is anybody lined with the fascia? You get the prize, you have given maximum correct answer, and you get the fellowship at Dubeji's place with 2 cochlear implant surgeries hands-on. Congratulations, you could say? Mansi from Maulana Azad. Great. So, the yellow one is the masticatory space and the red one is the infratemporal fossa. Both are different. The masticatory space is the facial compartment space lined by, all around by fascia. And infratemporal is open. It is not lined by fascia. The difference is, if any infection happens or malignancy happens in infratemporal fossa, it can spread anywhere quickly as compared to the masticatory space, which is lined by fascia as a barrier for the compartment to spread. Lateral boundary, like Vansi said, for the masticatory, is as it involves the masticatory muscles, is lateral to the masseter and temporalis. Medial boundary, the lateral boundary for the infratemporal is ramus of mandible. Medially, anybody? Which fossa is more medial? Infratemporal fossa is more medial till pharyngeal wall, but the masticatory is limited to the pterygoid process. A big difference, major difference is behind, which has a huge impact in the clinical setting. See this diagram. This is masticatory, but this is infratemporal fossa, this is masticatory. What is the big difference? This pre-styloid compartment venous plexus lies in infratemporal fossa. Any infection going to the infratemporal fossa can spread to the cavernous sinus, can spread to the orbital, to the veins, the pterygoid veins which are connecting these two spaces. But the infratemporal fossa is a cool space. Tumor arising in the masticator is a cool space. Tumor arising in the masticator is going to be limited for long because it has a facial barrier. It is not going to spread to the distal side because it has no aberrant venous connections like infratemporal fossa. So these two are different, they are not same. Now, what is the blue space? Blue space. Somebody has already answered. Parapharyngeal space is parallel to the pharynx. Still chocolate is there. What is the lowest limit of the parapharyngeal space? What? Greater corneophyre. What is the lowest limit for parapharyngeal space? You get the reward for this. Correct answer. Now we go to the clinical round. See. This is a 55-year-old male, proven squamous cell carcinoma. See the laryngoscopy picture. This is team A. 55-year-old male, proven squamous cell carcinoma. This is the laryngoscopy picture, and that is the CT scan on the right side. Question number 1. What is the stage of the tumor? It is cancer, laryngeal cancer. You see the vocal cord, mobile, good picture, laryngoscopy picture. Now what? You have a CT scan. What is the stage? Nobody, please, silence from the audience. Yes. What?
T4A stage. T4A, sir.
T4A is the correct answer. The stage is T4A. But how come the vocal cords are mobile?
Laryngeal.
Yes. Cartilage erosion. Look at the CT scan. In spite of the vocal cord mobile, the lesion, the third dimension of the lesion has eroded the cartilage, the thyroid cartilage, and made it T4A. So first part is absolutely correct. Great answer. You get 5 marks. Now what is the solution? What is the best answer to this?
Sir, solution like surgery.
What's surgery or radiotherapy?
Sir, as it is T4A.
You have 2 parts of the second answer for 5 marks. 2.5 marks. Whether surgery or radiotherapy. Next 2.5. What is the most appropriate surgery? If surgery. And if any other thing.
Sir, as it is T4A and cartilage is involved, so radiotherapy we cannot give. So surgery is the correct thing. And sir, which surgery?
Which is the most appropriate? You can get full 10 marks.
Sir, as cricoarytenoid unit is preserved, we can go for partial laryngectomy as well.
What partial?
Anterior partial laryngectomy. Anterior partial laryngectomy.
Yes.
Near total.
If you want one joint is preserved, so near total.
Voice conservation surgery.
Voice conservation surgery.
Early lesion, see? The entire larynx is normal except 5% of the larynx is involved. Rest of the larynx is normal. Can't be too radical to give a. Hello, madam. Yeah.
It's done by.
We'll go for vertical partial laryngectomy, anterior.
Okay, so partial laryngectomy, you get 10 marks, not vertical, it should be frontal partial laryngectomy. The lesion is for anterior. Vertical is for lateralized lesion. But your answer was correct, partial laryngectomy. See, such a lesion where the vocal cord is normal, it looks like a T1 lesion. That's why in any laryngeal cancer, however small it is, must get a scan done to know the third dimension. And look at the third dimension, how it has eroded the cartilage and made it 4A. Once cartilage is involved, radiotherapy is ruled out. Cartilage is involved, surgery is the mainstay of treatment. And for such a limited lesion, see the rest of the larynx is all normal, you can do a frontal partial laryngectomy. So you get full marks. Congratulations. Yes. So now, frontolateral when the other cord is fully involved. It is on the anterior part is involved. Frontolateral when the one cord is completely involved till behind. Now we go to the team B. Look at this surgery. Sandeep Pon is here, the rhinoplasty surgeon. Watch carefully. I have already given a clue, some rhinoplasty surgery is going on. See carefully. And this is operated by Sandeep only. So, some cartilage graft is placed, you must have seen. Did you see? Let me rewind. See this? Some cartilage graft is placed. I'll show you two videos. Let me know when you are done, that you are confident to give answer. Don't answer right now, so I can move to the next one. So what I want to ask is, which cartilage graft, what is the name of this graft being used? In rhinoplasty, there are a variety of cartilage grafts used. There are so many rhinoplasty workshops going on these days, and thanks to Sandeep, who has done more than 7 or 8 workshops in Jaipur, and many more rhinoplasty surgeons are doing. We have Sunil Tawar in Jaipur who is doing, Dr. Shubham is rhinoplasty surgeon. Many prominent rhinoplasty surgeons are here. So many workshops going on. So this cartilage graft, see how it is placed to do something for some correction. So this is one part. Second part of the video, so as not to complicate the things, this is another video. This is different graft for that matter. This is different graft. Earlier was a different one, and this was a different one. My question is, which carries 5 marks each? To simplify, what are these two grafts? A right answer will get you 5 marks straight away. Just name which graft is being used in video A, video B. For them, no? This is for you. Video 1, video 2, both. Which one?
Cantilever graft.
Video 2 is cantilever, he said, and video 1?
Stud graft.
Thank God this is a question I can answer in this quiz. I'm afraid you're both wrong. So we need to maybe go to the audience with this. Unfortunately, both of those answers the question. So what is video 1 showing?
Anybody? Yeah, first let them give a chance again.
Okay. No. So first, video 1.
Last chance. Anything you want to change?
Yeah.
So first one is septal extension graft. Correct answer.
Well
and
done.
he is our guest who has come all the way from Egypt. Hi dear. Great going. Thank you. Great answer.
Okay.
And this is a great gift from again from Mubarak.
Okay.
For his dear friend from Egypt. This is a rhinoplasty hammer. You can use it here also.
Congratulations. And so, what was
is
the video?
second?
What is the
What is
video
the second
B?
one? And get up. Columella strut. So you said columella strut. I'll give you prize. Tell me when is the septal extension graft is used. He said septal extension graft, the first video. And when is columella strut is used correctly?
To augment the tip also we can use columnar strut. Sir, to augment the tip we can use columnar strut graft, and The first one was septal extension graft. When the graft used like septal extension graft can be used like when the no sir when
There's a lot of cartilage, you can use it here and there.
That's not necessarily correct. There's one this man obviously knows, so you can't answer the second question as well. What is the major advantage of using a caudal septal extension graft over a columellar strut? Go ahead. Nope. Anybody else? Anyone was watching the videos or live operating, this was discussed. Gentleman at the back. Go ahead. Go ahead.
You deserve?
Ask.
He says I will give it. I don't know anything.
Well, he didn't answer it, but anyway, you got the chocolate anyway.
He didn't answer it.
He didn't answer it, but he gets the chocolate anyway. It's fine.
See, the judges can do anything.
No,
whether right or wrong.
The correct answer is that with the septal extension graft, it's free floating, so the risk is the tip may drop. So the advantage of using a caudal septal extension graft is it's a much more rigid thing. So if you've got particularly thick skin patients, it's a much better way of holding that tip in the correct position. Whereas with a floating strut, it's easier for thin skin patients, but you won't get the rigidity that you might need to keep the tip up.
Super. Finally, to get your queries answered. See now the next question for the team C. Look at this video. The 55-year-old male farmer. I specifically mentioned farmer living 400 kilometers away. Squamous cell carcinoma, proven. This video, I don't know how it stopped. There's a lesion on the cord. I can explain you. On the left cord. In the middle of the cord. Giving you too many clues. See the other lesion? Yeah, other patient, same category, farmer, 400 kilometers away. Biopsy has proven squamous cell carcinoma. What is the stage? Number 1. And what is the most appropriate one-line answer? One line means one line, no options. Please keep quiet for the benefit of the participants. You'll get a chance. It's a very important clinical condition I put up for the benefit of everybody.
Yeah, sure.
Can we see first video again?
First video again. Okay. Cord is mobile. It is in the middle of the cord. Squamous cell carcinoma. Patient profile is above, you can see.
Sir, it is T1A stage.
Stage is T1A.
Stage 1 means clinically CT1. Then, sir, appropriate treatment should be MLS.
MLS means?
So, microlaryngeal surgery.
Microlaryngeal surgery.
Removal of the...
How will you do? Use something to remove the speaker? Yes, so correct answer is transoral microscopic laser excision. So they get full 10 marks. The correct answer, part 1, is T1A. T1A is mid-cord mobile lesion on one cord, limited to one cord is T1A. Why transoral microscopic laser excision? I rewarded him 5 marks. Why not radiation? Anybody? Yes, that is one part. Other aspect? One part is correct. Coming back for the radiation again and again for 400 kilometers is one aspect for which you can consider a transoral laser resection. See, there is one principle in oncology I tell you. If there are two techniques wherein they give different cure rates, the one which give better cure rates should be opted. Whatsoever the consequences, morbidity, whatever. When the cure rates with two different techniques are same, the one which gives less morbidity should be opted. That's why the question is here. So here, the cure rates for the radiation and the laser are same. Almost same, 98 to 99%, depending upon now the technology has gone far advanced. You do a laser resection, limited one. Yesterday we discussed vocal cords as no lymphatics. It is so well limited to the vocal cords. No need of neck treatment. So, microscopic laser excision or radiation will have a same impact as far as the outcome is concerned. But why laser is chosen? The one part he has said that 400 kilometers will be difficult. Laser he can get done and go back home next day. No need to come again and again for 1.5 months, which radiation requires. What is the other part of the answer hidden? Voice is not required. So the answer is correct. You're good. Your name? Gita Ashko. Great. So out of these two modalities, the cure rates are same, but the voice outcome is little superior with the radiation. Since being a farmer, he is not a professional voice user, living 400 kilometers away with the same cure rates, but little inferior quality of voice, not a major difference. Marginally inferior, he can, live with that. So the correct answer is microscopic laser excision. So the reason is there in the question is a farmer living 400 kilometers away. Had he been a professional voice user, the treatment of choice would have been radiation therapy to give little better voice. Ultimate voice would have been little better. So we move on to the team D now. Team D is from Maulana Azad. Sit here this. 45-year-old old, again biopsy proven. You have a different situation. See the laryngoscopy. Vocal cords are mobile, I can give you a clue. It's biopsy proven. My question is straightforward. What is the best treatment option for this patient? Think twice before you speak. Anything. I hope the video is clear for you. Cords are mobile, biopsy proven, 45-year-old patient. Every word carries a value. Yeah.
Transoral supraglottic partial laryngectomy.
With neck dissection? With neck dissection?
If supraglottic, there are chances of
With or without neck dissection? Which side? So transoral supraglottic laryngectomy with bilateral neck dissection is his answer, which is absolutely correct. And they get a big round of applause from the audience for the very, very specific and correct answer. Now the other part of the question is, why supraglottic laryngectomy is chosen for this? Supraglottic laryngectomy has lots of, implication, adverse effects, post-operative, period is sometimes horrible. Why you have chosen and awarded with the 5 points? Still, your answer is correct, but why supraglottic?
Bilateral vocal cords are mobile. Voice can be preserved in a very normal.
But if he gets aspiration then? Why not radiation therapy? Still you get 5 marks more. Tell me. Why not radiation therapy for this? Why not radiation therapy for this? To me, radiation therapy is absolutely contraindicated for this patient. It's a clear-cut contraindication. Why? Definite contraindication. Why?
Surgically, we can remove it much better because radiation will.
Okay, surgically you can, but why I'm saying, what my question is, why radiation is definitely contraindicated?
Sir, it is a supraglottis involvement. So we have to go for the neck dissection of the patient.
You can do neck dissection with radiation also.
Yes, sir.
So vocal cords are mobile and radiation might also cause the other side effect, edema.
Why radiation, forget about the treatment now, that you got 5 marks. Why radiation is contraindicated? That is the question.
Other fields will also.
Where this can spread to whether radiation is contraindicated. I have given the biggest clue. Shh, please. Why radiation is contraindicated?
Sir, it will spread to other locations like pre-epiglottic space and base of tongue uvula.
The base tongue, treatment for the base tongue is radiation. Treatment of choice is radiation. I have given ample of clues. You have given little partial answer. You get 2.5. You get total 7.5. Now going to the audience. Why radiation is completely contraindicated in this case? Yes, yes. Get up. Come on.
The radiation doesn't work on fat, and in the pre-epiglottic space, if this cancer spreads, then radiation will not work in the fat.
Thank you, sir. So this Arjun, Dr. Arjun Gupta with the absolutely correct answer. This space, you know why this video is put up? Laryngeal surface of epiglottis is a notorious site. Any earliest lesion from the laryngeal surface, the lesion passes through the pores in the epiglottis to the pre-epiglottis space. In the earliest phase, this is too advanced. This patient must have, the pre-epiglottic space must have invaded by now, 100%. Even the earliest lesion in the pre-epiglottic, this infrahead epiglottis, spreads to the pre-epiglottic space by the pores in the epiglottis. And pre-epiglottic space is a relatively, avascular space, fatty space, and radiation doesn't work in such areas, in the hypoxic areas. So, and that too with the cartilage invaded. So radiation is contraindicated. Now why supraglottic laryngectomy? Anybody? Why not total? What complications supraglottic laryngectomy we are scared of? So why I written 45-year-old, he is not elderly. We can expect a good pulmonary function. We can expect this guy can tolerate, radiation, surgery, aspiration. So this is the right candidate for supraglottic. There cannot be a better example for supraglottic laryngectomy than this. Vocal cords are absolutely mobile. Pre-epiglottic space is invaded. Radiation can't be given. The right candidate for supraglottic, because had he been 70 years old, we would go in for total laryngectomy. Had he been 70 years old, we would go for radiation has no role. So this is the right candidate for supraglottic laryngectomy, and now is the time for marks. Anjali, scoring.
So total score for team A after round 4, 30. Team B 12.5, Team C 35, they are leading, and Team D 27.5.
Now is the time for the audience. Audience question. Prize question. Audience question goes to the participants also, because you are also, eligible to win the prize. Which of the following laser has least hemostatic activity? And you have to come up with a reason. Reason? Yes? With reason. I can take your hammer back.
Penetration power is more less, and the high less penetration power, and the high it is called pulse 10,000 something like this. It's more less.
Answer is correct, CO2, but why? Okay, If CO2 is not there, which other laser, which is not mentioned here, you can you enumerate any other laser which has least, hemostatic activity besides CO2? Beside these four, any other laser besides CO2 which has least hemostatic activity, you know? There are so many lasers, you know, erbium, yttrium, this, that, garnet, thulium, so many lasers. CO2 doesn't have hemostatic ability because why these three are hemostatic? These are all visible lasers. They have affinity for hemoglobin. They come in contact with hemoglobin and coagulates. KTP is such a good, hemostatic laser. Diode, argon, they are all, their wavelength is less, they are visible. CO2 is invisible, it cannot pick up the hemoglobin the way the other lasers pick up. So answer is CO2. Now, CO2 is invisible. You have to carry it through some other laser. Helium neon, you get the right answer. So it has to be carried through helium neon laser because it is invisible. Now, there are so many other lasers available. Still, why CO2 is so popular for the inner ear surgery, for everywhere? Why others are not popular? KTP is such a good tool. I have seen Ashish Bhumkar operating with KTP. It's a contact laser. You can precisely cut. You can do everything. But why for the stapes surgery CO2 is the best? To be very specific. Why? Why? Yes. So the CO2 is not absorbed by water. CO2 is absorbed by the water. Rest are not absorbed. This rest pass through. If you put a KTP on the foot plate, it will pass through the labyrinthine structures. But CO2 will be absorbed by the bone. So the heat will not be dissipated. So CO2 is the safest one. So Gauri wins the award. So CO2 is, out of all these lasers, is the best one. The other laser, which is invisible, can be used and doesn't have hemostatic property, is thulium laser. Not very popular, but it is. What does the thulium laser do? Anybody heard of thulium laser? It blasts like bomb. You fire bomb. So it produces acoustic waves like erbium laser, and it is so terrible for the patients. But still it is widely used where? Urology. तू क्या करेगा अभी खा के? So it is commonly used. Thulium is commonly used in urology. So the next visual round now. Team A, next visual round. Audio is on. I don't know why it is not running. Audio is on.
Answer is visible.
Anyway, my question is different. So, the voice you are not able to hear, doesn't matter. I'll show you the rest, the different part of the video. See this. See this. Short video. What is going on? Which surgery is going on, you have to tell. First, look at the video thoroughly. I hope this is clearly visible. What is going on? See what has been done. So the question is, what surgery is this?
Lateralization thyroplasty from the lateralization thyroplasty midline approach.
So it is which variety of thyroplasty?
Type 2.
Type 2 thyroplasty, the correct answer, lateralization thyroplasty. The incision was given in the thyroid cartilage in the midline and lateralized and place the plate so that it doesn't come back. Now, for what purpose it was done for?
Adductor, spasmodic adductor dysphonia.
So you have seen there, it was written. So what is the etiology of that? You get 7.5 marks. What is the etiology for that? Why does spasmodic dysphonia happens? Is it a local problem? When the patient tries to speak and then adductor spasm, that is the problem. So the problem is at what level?
CNS level.
CNS level, they get full marks. Give me what happens at the CNS level.
The impulse to the adductors of the larynx is more than
So this is an emotional aggravated mechanism because of incoordinated acetylcholine secretion at the CNS level leading to adductor muscle spasm. And this is such a terrible problem for the person who develops. So difficult to diagnose and so difficult to treat. And type 2 thyroplasty, which was described long back by Ishiki, is the answer for this. So you get full marks for the answer. Now we move on to the next. Anjali, maintaining the record?
Yes, sir.
What surgery is going on? B. This is some lateral skull base surgery going on. Not this is for the participants. Gauri. I give you a clue. This is some lateral skull base surgery going on. No, not for audience. Yes. So what surgery was this? Again? Microscopic surgery is going on. Lateral skull base, under magnification. In background also I can see something white. Yes, your time is. Attempt something. There is no negative marking. Five seconds, last 5 seconds. 3, 2, facial nerve decompression, where the nerve is being cut and you are saying decompression. So you don't get anything. Now the second part, still you have a chance to recover. Let me tell you, this was vestibular nerve section. Everybody knows. Am I correct?
Posterior neurectomy.
What?
Posterior neurectomy.
Posterior?
Singular neurectomy.
Vestibular neurectomy, I am telling. The correct answer. Now my next question, you can still grab 5 points. Vestibular neurectomy, you know why it is done? Must be knowing. For hearing. For Meniere's or any other vertigo. Does this sacrifice the hearing? So tell me other hearing preservation approach for the vertigo. For Meniere's, like you said. Hearing preservation approach. There are so many approach which treats the vertigo but destroys. This is one of them which saves the hearing as well. Tell me other procedure which is a hearing preservation procedure for Meniere's disease.
Shunt surgeries. Shunt surgery.
Which shunt? Yes. Endolymphatic shunt surgery is again a hearing preservation surgery for the Meniere's disease like vestibular nephrectomy. So you get 5 marks. So what are the destroying procedures? If the hearing is gone, then what is the best procedure? Gentamicin is the first line, even if the hearing is intact. It doesn't mean that gentamicin is always going to take away the hearing. Labyrinthectomy is the final answer. If the hearing is gone, gentamicin is not working, medical treatment is not working, then you have to go to the ablative procedure, that is radical labyrinthectomy. There are 2 ways. Transcanal, postoral, you have to destroy the entire larynx. But this procedure is a rewarding procedure where you preserve the hearing. So in acute situations, when nothing works and the hearing is good, this is the procedure of choice. Now, you have 2 videos coming as a part of this question. This is one. Something is being done with some tool. This is the second part of the video. There are 2 videos. What tools are being used in 2 different videos? First part of the question. Every correct answer carries 2.5 marks.
Team C.
2.5 for one correct answer. So you have to answer 2 different tools are being used in these 2 different videos.
So one is laser.
These 2 different. Could be laser. What laser? What is in video 1? What is in video 2? Very, very specific answer. You may be correct.
So first is CO2 laser.
First is the previous one. Let me run again. Yeah, this one. This one CO2. And the next one? This one? So your 5 marks are gone as your first answer was wrong. The first video, this was which laser? I just told you 10 minutes before is a contact laser, KTP laser. And the second video belongs to, this is one shot CO2 laser with the aiming beam. See, there is no tool in between. Aiming beam. So you have lost 5 marks, but you have again chance to recover 5 marks. The CO2 and the KTP, the difference we have already discussed. One is a hemostatic property, other is what wavelength belongs to the CO2, what is the wavelength of CO2 and what is the wavelength of KTP. Which is a less wavelength, which is a more wavelength. Tell me finally. You'll get 2.5 marks for that. But if you give me correct answer for the wavelengths, even approximate, you'll get 5 marks. We have discussed this in detail just now. Already answered this. Guess. So you get 2.5 marks. KTP has less wavelength, so he gets 2.5 overall. So the wavelength of KTP is? 532. Yeah, roughly. See, we have already discussed the CO2 is invisible laser. So the wavelength is too much as compared to the KTP. The first contact laser was the KTP one. And the second is the CO2. CO2 is always preferred because it gives less chance of sensory hearing loss as it reaches to the perilimb with minimum chance. Now see for the team D. Leaving. Okay, bye. What is this video? What surgery is going on? What I can give you a clue, it was a dura which was opened. Please keep quiet for the audience, for the participants' benefit. It has become so clear. I have given you ample of clue. Something is placed there, some foreign material. I said it was dura, and then see what happened. What is this? What surgery is this?
It's a brainstem implant. Brainstem implant.
Are you sure? Still you can see surgery is going on. Lock कर दूं? No negative marking.
Sir, it's an implant, but brain stem implant is maybe probably.
For?
Sir, whenever there is 8-nerve agenesis, for which such conditions we do it?
So this is auditory brainstem implant. Your answer is correct. You get 5 marks. You have given one region that why it is done. Auditory nerve is not there, so how can you connect with the cochlear implant? So now you saw the implant placed. This is auditory brainstem implant. You are correct. Where exactly this implant is placed? What do you stimulate with this? What do you stimulate and where exactly the location where you place? 2 parts, 2.5 each. In cochlear implant, you stimulate cochlea.
Sir, it is placed in the lateral. Sir, so it is placed in the lateral wall of the fourth ventricle.
In the lateral part of the fourth ventricle.
Yes, sir.
To stimulate what? What to stimulate?
Sir, cochlear nucleus.
Correct. So you have to we stimulate the cochlear nuclei with this, the dorsal and ventral cochlear nuclei, in the wall of the lateral part of the fourth ventricle. You know, there are certain landmarks there, if you have heard of this surgery, seen this surgery sometime, which are to be utilized to access the cochlear nucleus, to access the fourth ventricle. Anybody give any landmark, will get a big prize. Yes. Choroid plexus is correct. Glossopharyngeal is no role. Choroid plexus is the correct answer. Your name? From? So have you seen ABI surgery sometime? Oh, correct. So it is being done in RNR? So correct answer is you have to see the choroid plexus. Choroid plexus give you idea where the fourth ventricle is. And the lateral part of the fourth ventricle, that foramen is known as? What is that foramen? Lashka. The lateral one is the Lashka. You elevate, retract the choroid plexus and you see right the cochlear nuclei. So that's the correct answer. And now is the time for the numbers before we go to the final round. Yeah, they get 10 marks. Now the question for the audience, and it has a prize. Let me announce some prize. It has two parts of the question. This question has two parts. Read it carefully. It's a very important condition. And the prize is, like Mubarak announced, a fellowship with him with hands-on ear surgery, maybe endoscopic ear surgery, a 15 days fellowship with him at his place. So let's give a big hand to Mubarak for all the encouragement, support and help. So the question part is, which of the following genetic mutations are responsible for significantly increased risk of malignancy in paragangliomas? SDH means succinate dehydrogenase. The mutations in the succinate dehydrogenase are responsible for development of paragangliomas. We must know this fact. Part 1 is, which mutation predisposes to malignancy highest? Which mutation predisposes to multicentricity? And how mutations, this succinate dehydrogenase is connected to paragangliomas? Anybody? Prize is a big one. Answer whatever you can. B is the correct answer. Correct answer. Those who have B mutations have highest propensity to develop malignancy in paragangliomas. Now for multicentricity. Who said? D is for multicentricity. So those who have succinate dehydrogenase D mutations have multicentric lesions. You know the American Society of Oncology's guidelines. Any tumor which has more than 10% chance of familial occurrence or mutation has to, by default, undergo genetic testing. It is not happening in our country. So the cost limitation, so many things are there. But any patient with a 10% chance of mutation has to undergo genetic testing, and it is so important because you can pick up the disease by means of genetic testing earlier, even before clinical manifestation. So this paraganglioma has 30% chance of mutation. Ideally, all paragangliomas, sporadic, whatever, should undergo genetic testing. Genetic testing of first order relatives at least. So like somebody has paraganglioma, his first order relatives are tested. If genetically positive, they should be kept under close observation for any development of any paraganglioma. Now, what is other test which can check the paraganglioma all over the body? Yes. Yes, DOTA scan. So, what does DOTA scan test? The answer is correct. It can do that. Amazing test. We get sometimes done. It can pick up paraganglioma anywhere in the body. If you have a paraganglioma, suppose jugular here, you get MRI done, this, that. Don't test the whole body. There could be somewhere reason elsewhere as well. DOTA tests somatostatin receptors. And paraganglioma is extensive somatostatin receptor. So DOTA testing will tell you wherever the paraganglioma are. Your answer was correct. And DOTA is most useful in this setting. Why don't you get a DOTA test so commonly? In revision situations, when the MRI, CT scan are not so informative, there could be fibrosis, could be disease, could be something else. DOTA will tell you whether there is disease or not. So DOTA is most useful when you are suspicious of multicentric lesion. If you have not done the genetic testing, at least get the daughter testing done to see multicentric lesion. And in revision system, you have done a glomerular surgery, put the fat, muscle, whatever, and you know the revision to pick up by all these means CT and MRI is so difficult. It is not cancer where you can do a PET scan. So DOTA is the investigation of choice which picks up somatostatin receptors. So who said earlier? You said. You also get this prize. So the last round, see team A. Have you announced? Just a minute, just wait a minute. You announced the scoring.
So scores after round 5, Team A leading with 40 points,
Super.
Team B 17.5, Team C 37.5 and Team D also 37.5.
Close fight, anything can happen. Team C and D are in close contest and Team A is leading. And Team B has no chance to lose now. Any single answer can get them out of the race. Wrong answer, any single wrong answer. So now, yes. So see this video. What is this maneuver? Please. G3 आपके गलत आंसर से हार जाएगी. Some maneuver is going on. Obviously, these maneuvers are related to vertigo. There are so many maneuvers. Any idea? A correct answer will get you 5%, 5 marks.
The barbecue.
Super. Ultimate. Give them a big hand. This is barbecue roll maneuver. Ultimate. Next part is for what it is done. It has 2 parts. So next question is 2 parts. For what pathology it is done. And how can you diagnose clinically that pathology? If you have any clue. 2.5 for each. What pathology is this barbecue? You have given superb answer.
So for BPPV? BPPV.
BPPV is Apple's maneuver, so many other maneuvers. Everybody has started his own maneuver. His name.
The posterior semicircular canal.
What?
Posterior semicircular canal.
Posterior semicircular canal.
Superior semicircular canal.
This is wrong. The next part, you still have a chance to get 2.5 marks. This is done for which BPPV? Lateral canal BPPV.
Barbecue.
Yes, this is done for lateral canal BPPV. Now, can any clue? BPPV is most common with the posterior canal. And we know the reason I disclosed yesterday. Know the reason? Because the most dependent canal. Otoconia comes released from the utricle and settled down by gravity in the posterior canal, because this is most dependent canal by gravitational effect. So now, how can you have a suspicion of a lateral canal vertigo? It is almost always so common in the posterior canal. How come the lateral canal vertigo happens? How can any clinical clue to give you, to make you do this maneuver? How will you diagnose? I'll give you one more chance for 2.5 marks if you don't know this. What other maneuver for the lateral canal BPPV? You can have any other maneuver.
Simon's liberatory maneuver. Simond.
Absolutely wrong. You get only 5 marks. So, other maneuver for the lateral canal? Lampert.
Supine roll.
That is a test.
270-degree long roll.
We are talking of the answer, solution. That is test. Name of the maneuver.
270 degree.
Come on. Yes. Buffoni's maneuver is other. I'll give you 2 more. When Buffoni, when barbecue. Buffoni is other maneuver which is for the treatment of lateral canal vertigo. He said. Barbecue, she has answered, she is correct. Buffoni is answered, she is correct. When to do Buffoni, when to do barbecue. Yes. Amazing. Amazing. It has other terminology also. Apogenetic, other terminology also. You are correct for canal lithiasis and cupulolithiasis. Yes. You get double. So, if it is a canal lithiasis, then it is barbecue roll maneuver. If it is cupulolithiasis, then Buffoni's maneuver. Now, for this was for lateral canal. What is Simond maneuver? Simond is for which canal? Posterior canal. All everybody knows. Any place? Any other maneuver for the lateral canal? Buffoni, barbecue roll. Heard of Zuma maneuver? XUMA. See, these are different maneuvers directed by different planes. Barbecue is in the horizontal plane. Buffoni in vertical plane, frontal plane. So the aim is same, to get the autocunia out, but the maneuvers are different. Now, team B, you can't afford to lose any single mark now, otherwise you may lose the race. It has 2 parts. This question has 2 parts. Oh, come on, why the voice is not coming? लगाओ इधर इधर लेना वॉल्यूम बढ़ाओ थोड़ा सा आया वॉल्यूम बढ़ाओ So listen to this sound. This sound. Yes. Yes.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10.
He's a 13-year-old male, 14-year-old. Heard his voice correctly? Now see what is being done. See the voice again. Hear the voice again.
4, 5, 6.
He has done something and change in voice.
8, 9, 10.
For the participants, please. So, what is your diagnosis first, and what the test he did?
Diagnosis pneumonia and the test is Cashman's test.
Again?
Diagnosis is pubelphonia and the test is Gutzmann's test.
So that's the correct answer and they get full 10 marks. So what is done in Gutzmann's test?
So we are giving compression over the trachea and we are helping to lower the pitch of the voice.
So Compression, it is frontal back compression.
Continuous compression will have the patient.
Compression is directed inferiorly to pull the vocal cord. The compression is not anterior-posterior compression. It is posterior-inferior compression. So the vocal cords are pulled and this feminine voice is improved to a male voice. If this happens to occur, purophonia, and doesn't, no treatment is effective, we all know. Speech therapy doesn't work sometimes. What is the answer? We discussed yesterday, that is type 4 thyroplasty. This is androphonia, and to correct is to make the vocal cord tense. And opposite is the type 3, when you make the vocal cord. Yes. So, how is the type 3 thyroplasty done for the audience? Can anybody describe? Can anybody describe? You will get a special prize. Dr. Ashim Desai announced. He designed a special equipment. His father, A.B.R. Desai. It's a set of micro ear instruments wherein, because he has the maximum, stapedectomies done in our country. More than 6,000 you must have heard in his oration yesterday. So he devised a special tool to measure the size of the fenestra. And he has promised us to give someone for the correct answer in the quiz. So how is type 3 thyroplasty done? Can somebody describe in brief? Yeah, he is also. Yes? To keep it pressed. So, a window on either side of the midline, 2 incisions are given on either side of the midline, and that cartilage is pushed behind and kept in place by suturing the rest of the thyroid lamella, so the vocal cord gets relaxed. So that is for type 3. And your good name, sir? From Indore. Naam likh. Ashim go. Ashim will give him. Congratulations. That's a very, very useful tool, unique. You'll not get anywhere by any company. His own creation. Superb. For team C, look at this. What happened? Okay. See this video showing all bones of the skull. See, skull is composed of so many bones. And what a complex structure. See, this structure is, we all know, must be knowing. What is that? Huh? Less serving of sphenoid. Great. So it has 2 foramina on either side. There are certain things pass from this side, certain things pass from this side. You'll get full marks if you say correctly what all passes through this. Yes, sir. What passes? First of all, what separates these 2 foramina? What are these 2 foramina? Canals, foramina, whatever. And what separates? Yes. You get 5 marks straight away. The medial one is optic canal. and the lateral one is superior orbital fissure, separated by? There is a bone which separates these two. The bone which separates, I always describe in our dissections, the bone which separates the optic canal from the superior orbital fissure. It carries 2.5 marks. You have already got 5. There are structures like optic nerve is separated from the optic canal, separated from the superior orbital fissure by some structure. The superior orbital fissure is separated by foramen rotundum by separate structures. So this is the structure which separates. You have correctly said right one is the superior orbital fissure, the left side is the optic canal. The bone which separates is no negative marking. No. What is the correct answer? Optic strut is the correct answer. Your good name, sir? Islam. Correct answer. So, optic strut is the bone which connects the body of the sphenoid to the lesser wing. And that separates the optic canal from the superior orbital. Still you have a chance to grab 2.5 marks. In superior orbital fissure, what is the inferior most structure? Correct. She gets 2.5 straight away. Inferior ophthalmic vein is the inferior most structure. This is so important answer. The reason being, this is just above the maxillary strut. If you are operating in that region and if you happen to damage the inferior ophthalmic vein, it has a great impact and it can even lead to a lot of, deficit and even result in a blindness. Because that goes to the cavernous sinus. The thrombosis can lead to a lot of problems. So that's a very, very important answer. And you get 7.5 marks. So guys, now you have chance to, you are running neck to neck. You must be bored of videos. Let us come. Your question was different. Yes. Very important question. We discussed a little bit of it yesterday. There is now nervous intermedius. You all must have heard of. It joins the facial nerve. Facial nerve has its own fibers and additional fibers come from the nervous intermedius. So which of the following fibers belong to nervous intermedius? Preganglionic fiber to the submandibular, sublingual, anterior two-third tongue test sensation, prelingual to the lacrimal, nasal and palatine, sensation from the part of the skin of the external acoustic meatus. All of the above, only C and D, only NB. See, all these are where the facial nerve through its branches goes. So which of these are contribution from the nervous intermedius? No, this is for them. Please. You'll get 2 chances. I'll give you a clue. The first chance, you'll get 5 marks. If you give absolute correct answer, you'll get straight away 10 marks. All these are facial nerve supplying. There is no doubt about it. The question is, what all are the contributions from nervous intermediates? I hope the question is clear. So which fibers are the nervous intermediates are contributing to this ABCD? Wait. Okay, I'll give you second chance. You try one answer. If it is wrong, doesn't matter. There is no negative marking. We'll get.
Nervous intermedius is a sensory nerve of the facial nerve.
I don't know. You tell me the answer.
All of them.
You say?
Sir, D is right.
T is correct.
Yes.
Okay. What about ABC? EFG? If you give one single correct answer confidently, I will get 10 marks. If not, you lose 5 marks and then I will go to the second part of the question.
Sir, I will go with the E.
All of the above? Correct answer, they get 10 marks. Superb. See, all these are sensations, all these areas are contributed by nervous intermediates. It is such a slender nerve, but the contributions are maximum. These are not contributions of true facial nerve. True facial nerve is a motor nerve to the facial expression muscles. Rest all are contributions from the nervous intermediates. And see this sensation from the part of the skin of the external acoustic meters. Has it any bearing? Have you heard of this part of the sensation is affected by some disease?
Yes, sir.
Hitzelberger sign in acoustic neuroma, because of the tumor pressure, it affects the sensory part of the facial nerve, part of the nervous medius to give loss of sensation in the external acoustic meters. Your good name, sir? From? Ahmedabad. Great. So, that is what, and congratulations for the correct answer. So, all these important fibers are actually the fibers of nervous medius, not the per se coming from the facial nucleus. So, now we complete our rounds and quickly move on to the rapid fire to conclude the session. So, can you announce the results?
Yes, sir.
So far, scoring.
Audience, any guesses who is leading? Team D is leading with 47.5 marks. Team A 45 marks. Team C also 45 marks. And Team B 27.5 marks.
So, who is leading?
Sir, Team D. And tie between
47.5, 45.
Team
So,
A
the
and
pendulum
Team C.
is going here and there. Huh? So, Team A has to, brace up now to maintain their lead.
Sir, first slide. या फिर randomly लेना first slide नहीं है उसमें.
Yeah. So now the rapid fire, every team will get 10 questions. But the time is not much. You have to quickly answer true or false. There is no negative marking. And Anjali will immediately tell you correct or wrong, and she will do the scoring also. And you have to correct him if she scores wrong, because this has to be done quickly.
No,
10.
total.
That doesn't mean that you answer slowly. You have to be quick, because anyhow this is not going to extend beyond 1.5 minutes. If you are slow, you will get less question. From 1 minute, I have given 1.5 minutes. No negative marking, and every correct answer will carry 5 marks. Okay? So you all have a chance to, again recover. Start. Team A. Dupilumab is a FDA approved monoclonal antibody for treatment of CRS.
Incorrect.
Recruitment is positive in Meniere's disease.
Correct.
Pericranial flap is a common flap based on branches of internal carotid artery. I want answering true or false, not yes or no. Fast.
It's false. False.
Incorrect.
Why did you get confused? Center of the reflex arc for the stapedial reflex is inferior colliculus. Quick.
True.
Incorrect.
Incorrect. Pure tone audiometry universally starts with 1000 Hertz frequency first, then in a frequency order ends with the 250 Hertz. This is a universal sequential order. Starts with 1000 and ends with 250. Is it correct or not?
Speech frequency. True.
Correct.
Majority of the head and neck paragangliomas are non-secretory.
True.
Correct.
Patients with Sjogren's syndrome have high risk of developing lymphoma of the salivary gland.
Correct.
Fistula test is always positive in case of large labyrinthine
False.
fistula.
False.
Correct.
Horizontal or vertical direction changing nystagmus is suggestive of central vertigo.
True.
Correct.
In unilateral sensorineural hearing loss, contralateral stapedius reflex is also absent.
Timer done. Timer.
Thus,
It's,
quick.
It's true.
Incorrect.
Incorrect. So,
You have 6 correct answers and 4 incorrect.
so 6 correct. Good. You could have, earned more. You had at the last minute change your answer. It could have been 8, so you scored 30 marks. Good. So, the correct question is, Dupilumab is a FDA approved monoclonal antibody for treatment of CRS. And? Yes, they said no. It is yes, that's the only FDA approved monoclonal antibody for CRS treatment. It blocks which receptors? Which price? It blocks which receptor?
Put a word.
I 4 and 13. Why did you speak 13? 4 and 13, it blocks. Recruitment is positive in menias, they were correct because it's a cochlear disease and there is always recruitment positive, they are correct. Pericranial flap is based on branches of internal carotid. She was saying yes, then say no. So, which branches of internal carotid? How come it is branches of internal carotid supplying the pericranial flap? What are the vessels for a pericranial flap? What are the vessels for a pericranial flap? Oh?
हाँ सर
What are the vessels?
मेरा बैग में दिया
Vessels for a pericranial flap. They are branches of.
अरे ये भी तो पढ़ी है.
Correct.
ये भी तो
So that is a branch of internal carotid and supraorbital and supratrochlear are branches of ophthalmic. So it carries the blood from the internal carotid circulation. Center of reflex of arc of stapedius is inferior colliculus. Superior olivary complex is the reflex arc. I didn't expect this wrong answer from you. You are super intelligent. How come you answered superior inferior colliculus? Pure tone audiometry universally started with 1000 frequency and ends with 250. That's correct answer. Now what is the sequence? Anybody gives will get a big prize. University audiometry everywhere is done in London, US or Jaipur. It has a universal sequence to test frequency wise. What is that sequence?
500. It's 500,000.
Starts with?
500,000.
Starts with 1000.
I said that is correct.
Start with 1,000.
So it's 1,000, then higher frequency.
Anybody?
It's
Yes.
1,000, then 1,000, then 2,000, 4,000, 8,000, then 500.
No.
It again 1,000.
You were quite close. You were quite close.
ये सब तो पढ़ ली सर
मेरे को एक चीज समझ नहीं आई
ये गोल्ड मेडल किसी
Yes. Again 1,000 now you have come in. That's the correct order. 1,000, 2,000, 4,000, 8,000. Then again 1,000. You are the only one. Okay, sir. We just for you. If you don't use, give me back. So 1,000, 2,000, 4,000, 8,000. Then again 1,500. You didn't say earlier again 1,000. Now tell me why 1,000 again once you have tested earlier. You have to know reasoning for everything. 1,000, 2,000, 4,000, 8,000. Why 1,000 again? Then 500. If you give me a reason, I will give you one more. Anybody? Anybody? Why 1,000 again? There has to be reason for everything. Once you have gone up to 8,000, yes?
It lags in the speech frequency. Something related to.
See, once you go to the higher frequency, that tone changes. And now for after 8,000, you come back to the 500, it's just a vibration, not even tone. So you have to apply the patient again, that you are hearing a tone again. The 1,000 is the most familiar one. So I again say that yes, here, then 5,000, and 2,000. If you come from 8,000 to 500, they will never understand. So you are asking for a tone and now it is a vibration. So you have to familiarize again by giving 1,000 frequency tone, that so that they can recognize 500 and 250. Majority of the head and neck paragangliomas are non-secretory, yes. How many percentage are secretory? 3%. Exact. My God. 3% are secretory. Sjogren's syndrome, high risk of developing lymphoma. How many times risk? This is something important. Sjogren is considered as a benign disease, autoimmune disease. Steroids are given. Yet as a high risk of developing lymphoma. You said correct answer. Anybody, you'll get a special prize. How many times the Sjogren has a chances of developing lymphoma? You know, 44 times. Anybody has a Sjogren has a 44 times chance of developing lymphoma. So Sjogren don't consider lightly. Sjogren, why I am saying the Sjogren diagnosis is sometimes difficult. You have to be very watchful, otherwise these patients are ultimately diagnosed with lymphoma. A missed Sjogren diagnosis, developing lymphoma and then diagnosed. That's so unfortunate a part. So we have to be very careful about diagnosis of the Sjogren. Fistula test is always positive in cases of large labyrinthine fistula. They said no, incorrect. Yes. Why this is not? Why it is not always positive in large labyrinthine fistula? Why it is not always positive in large fistula? Fistula is so big. Why is it still fistula test is not positive? So what is there always? The answer. Huh? I think one of the problems. Why it is not always positive in such a big and large fistula? So what? Dead labyrinth will not show test. Why did you say? How come the large fistula is always positive? The labyrinth is dead, it will not give. Horizontal, vertical, direction changing nystagmus suggests you central vertigo. Yes, the peripheral is not direction changing. In unilateral sensory loss, hearing loss, contralateral, stapedial reflexes. See this question. The big prize 10 days fellowship at a premier center if you give this correct answer of stapedial reflex for everybody. Let me repeat this question. Patient has a unilateral sensible hearing loss. Contralateral stapedial reflex is also absent. Contralateral means unilateral side loss means when you give stimulus from here. And the contralateral is giving from there, and the stapedial reflex is absent because here there is unilateral complete sensibility. So, and I said this answer is wrong. Whatever is written is wrong. How come? Can you explain the contralateral and unilateral cross stimulus from the other ear and it will lead to sensations may go from the other ear and that will lead to stapedial reflex. In the dead ear. This may be dead ear, unilateral sensibility loss.
Sir, it is particularly to the seventh now. So if you stimulate the other ear will stimulate the cochlear nucleus to the ear now, but different path is to the seventh now. Seventh now is intact on the affected ear.
That's great. You are also right. But he has explained it well. See, this ear is dead ear, the sound is not going. So all ipsilateral reflexes are absent. But the seventh nerve is normal, stapedial is normal. It is sensitive, this is not conductive. Conductive, that could be absent stapedial or stapes or anything that could be. So now, if you stimulate the other ear, the sound and reflex are going to go to superior auditory complex to the eighth nerve, which is normal on the opposite side. There the fibers deconcentrate. And the efferent go as seventh nerve to the nerve superior, which is normal in this. And here it doesn't have a facial palsy. Here the unilateral hearing loss, the efferent path is intact. So if you stimulate the opposite ear, you will have a contralateral reflex. This is such an important bearing in the clinical practice. You know, one can have a false negative release test in unilateral sensory hearing loss. You know why? You all know why? Opposite cochlear stimulus and the test of choice is stapedial reflex. In unilateral sensory hearing loss, always test the stapedial reflex. And if you get a contralateral, the audiogram was wrong. Get the audiometry. Just to learn again the audiometry, you didn't do masking. But my point, this is how you can test your audiometry. So your name again?
Sohil Vadia.
Sohil Vadia, you are welcome to our center for 7 days, any point of time.
Thank you, sir.
Sir, contact Arjun.
Congratulations. Yeah, you can contact Arjun. So the team A is got 30 points. Now we move on to the, so your round is over now. We will announce the results after that. Now, team B, quick. Direction of the nystagmus is defined by the direction of its quick phase, fast phase.
Correct.
Posterior semicircular canal of one side lie in the same plane as superior canal of opposite side.
True.
Correct.
Recovery mode. Vagal paragangliomas arise from the nodose ganglion in almost all cases.
False.
Incorrect.
Anterolateral thigh free flap is a myocutaneous flap.
True.
Incorrect.
DOTA scan can be useful modality for paraganglioma diagnosis.
True.
Got the
Correct.
answer earlier. One is over?
सर वो आप उसको ऑन करिए.
All anaplastic thyroid tumors are classified as stage 4, all, regardless of the tumor size.
True.
Correct.
Pharyngeal pouch is herniation of mucosa through two components of inferior constrictor muscle.
True.
Correct.
Epiglottis is a fibrocartilage which never ossifies.
True.
Correct.
Medial surface of tympanic membrane in its entirety is supplied by glossopharyngeal nerve.
True.
Correct.
Last one, Bill's bar separates facial nerve from cochlear nerve.
False.
Correct.
Correct.
So
how many?
So you have 8 correct answers and 2 incorrect.
Oh my God, recovery. Good. So, Bill's bar separate facial nerve and cochlear nerve. This is correct.
बंद कर दो अब तो बंद कर दो सर डिस्कस करेंगे बता दो
Vestibular to facial nerve. On medial surface of the tympanic membrane, in entirety supplied by glossopharyngeal nerve. How the lateral surface is supplied? If somebody gives the correct answer, he gets double prize. Correct? Correct. Otherwise, I will snatch your chocolate.
सर 3 बज रहे हैं बच्चों को भी खाना खाना है लंच नहीं मिलेगा अंजलि बोल
मैं नहीं बोलूँगा
मेरे को तो डांट पड़ेगी आप तो वैसे खा रहे हो ये बड़े इन्होंने बताया हमें
क्या बताया
कि हमें गाली पड़ने वाली है
क्यों
मतलब ऐसे काम करोगे तो गाली पड़ेगी
कोई बात नहीं वो प्यार है और आप लोगों के लिए बहुत प्यार है
सर लड़कों तो गाली
हाँ तो वो रुक जाता है he knows अभी
Both deserve this. So this is important in infiltration. See, this is how the patient develops vasovagal. Because the posterior half of the tympanic membrane is supplied by the vagus. If that is stimulated, can lead to bradycardia. Epiglottis is a fibrocartilage which never ossifies. It was correct. Any other fibrocartilage in head and neck? Commonly, you know. Fibrocartilage. Anybody? Yes, pinna. Pinna is a fibrocartilage. It never ossifies. Pharyngeal pouch is hernia because of the two component of inferior constriction. What are two components? Ecopharyngeus. And all anaplastic tumors are classified stage 4 regardless of the tumor size. They say correct. Yes. Anaplastic have grim prognosis. You know, the moment they are diagnosed, their life expectancy is limited. So anybody diagnosed with anaplastic is always stage 4. If it is limited to the thyroid, it's stage 4A, goes beyond the thyroid, stage B. If it is limited to thyroid, stage 4A, then you can think of removing it and introducing further treatment. क्या हो गया इनको? ऊपर नीचे हो गए? नहीं
ऊपर नीचे इसीलिए सब कुछ दिखते हैं इसलिए मैंने वो हटाया बीच के लिए दूसरा डायरेक्शन
2 8 and 2 था
8 and 8 slides 8 even
So, and the other 5 words, direction of nystagmus is defined by the direction of quick phase was correct. Quick is a correcting phase, you know, and that's how their direction is described. Posterior semicircular canal of one side lie in the same plane of superior canal of opposite side. See, both canal, you know, they work synergistically. The horizontal canal of both sides are in the same plane. Posterior canal of one side and the superior canal of opposite side are in the same plane. That is correct. Vagal, your answer was wrong about the vagal paragangliomas. They almost always arise from the nodose ganglion. Big question for the audience. Huge prize. And you will get a book from a renowned author for that. What is nodose ganglion? And what are the other branches of the nodose ganglion? 2 other branches, nerve branches of the nodose ganglion. Be very, very specific about that.
Pharyngeal nerve.
Anybody?
Pharyngeal nerve. Superior laryngeal nerve.
Oh, super. Pharyngeal nerve and superior laryngeal nerve are 2 branches from the nodose ganglion. Super. Big round of applause to you. And you will get a book I'll give you immediately after this from the, that's a rhinoplasty book. I'll give you after that. So, inferior nodose ganglion or inferior vagal ganglion This is in the temporal bone, in the jugular foramen, and it gives rise to superior laryngeal nerve, which divides it later on in the external and internal branch, and the pharyngeal nerve. And pharyngeal nerve, which pharyngeal nerve? Which carries fibers from? Cranial part of the 11th nerve. That is what pharyngeal nerve is. I told you yesterday as well. Anterolateral thigh flap is a myocutaneous flap. It's wrong. It's a fasciocutaneous flap. Doesn't contain muscle. A DOTA scan we have already discussed. First. Okay, team C, quick. HPV 16 virus type is the most virulent of all HPV types causing cancer.
True.
Incorrect.
In normal individuals, irrigation of left ear with warm water will cause nystagmus to the left side.
Correct.
Cows. Horner syndrome results from interruption of the parasympathetic nerve supply to the orbit and face.
Correct.
Cricoid cartilage is hyaline cartilage which can ossify with age.
Correct.
Vowels are low frequency sounds while consonants are high frequency sounds.
Incorrect.
Fissures of Santorini are dehiscences in the bony extraordinary canal to permit infection to extend to parotid and vice versa.
Incorrect.
Nystagmus of peripheral origin lasts only for a few seconds, while of central origin lasts as long as the head position is maintained.
Correct.
FDG PET scan positivity is almost always highly suggestive of malignant lesions.
Correct.
Adenoid cystic carcinoma is one of the fastest growing malignant tumor of the head and neck.
Incorrect.
Lateral recess of sphenoid sinus is over-pneumatized at the expense of pterygoid bone. So over-pneumatization at the expense of pterygoid bone.
Incorrect.
Lateral recess is always because of pneumatization of the pterygoid process. How come you got confused? Am I correct?
You have 5 correct answers and 5 incorrect answers.
Yeah. That the question, I'll come to that question.
Slide 1.
So lateral recess is always at the expense of pneumatization of the pterygoid bone. Adenoid cystic carcinoma is the fastest growing malignant tumor. It is rather very slow growing malignant tumor, but it has a tendency, it has certain characteristics. Anybody in terms of prognosis, long-term prognosis. Long-term differences are there, and many a times it fails not locally. Patient local lesion cured, but 10 years down the line it develops distant metastasis. This is classical of adenoid cystic carcinoma, and there is a marker study we do for something to test in adenoid cystic. Anybody? Which marker is specific for adenoid cystic? C-kit is very, very specific for adenoid cystic. Yeah, nystagmus of peripheral origin lasts only for a few seconds. Yes, central is as long as it's given. Fissures of Santorini are dehiscences in the cartilaginous extraordinary canal, and you were wrong. Yeah. So your question was HPV 16 virus type is the most virulent. The question was most virulent, and you said yes. It is most common, not virulent. The most virulent is HPV 18. You know, now a new vaccine has come. Gardasil 9. It covers which 9?
6, 11, 16, 18, 41, 43, 45, 52.
31, 33, 45, 52, 58. All 9 common species which are likely to give malignancy. If you give Gardasil 9 vaccination, is almost 100% protection from the HPV malignancies, HPV driven malignancies. In normal individual, irrigation of the left ear with warm water will cause nystagmus left side, correct. Horner syndrome is interruption of parasympathetic nerve supply. It is, you are correct, it is because of interruption of sympathetic nerve supply. What all happens in Horner's?
Anhydrosis.
Why meiosis? Why meiosis happens? Yesterday I told you. Paralysis of Buller's muscle. This is the upper artery. Then, why meiosis? Responsible for dilatation of the pupil. Oculomotor through his fibers is responsible for constricting the pupil by means of acting on the constrictor pupillae. So once the sympathetics have gone, the pupil dilates. Meiosis happens because pupil constricts. Cricoid cartilage, the hyaline cartilage which can ossify with is correct. Vowels are low frequency sound while consonants are high frequency. This is so important. This is correct. What happens in high frequency losses? Difficult to understand consonants. You must have known people with hearing loss, literally high frequency. They hear the sound but they don't understand. The reason is the consonants are difficult to understand because the high frequency is lost. So accordingly the frequency 5 amplification is required for those patients, you know.
Next.
So we move on to the, how many correct?
5 correct.
So they get 25 marks. So after this is the last one and then Anjali will announce the results. Among rhabdomyosarcomas, the alveolar variety are the worst prognosis.
False.
Incorrect.
Stones in Wharton's duct cannot occur after complete submandibular gland excision.
False.
Right.
Anion is the landmark denoting junction of the upper and lower lateral cartilage. Lower.
False.
Correct.
Mucor species demonstrate non-septate, aseptate, wide angle, high Fion histology.
True.
Correct.
HPV 16 and 11 are predominant etiological factors for recurrent respiratory papillomatosis.
True.
Correct.
Majority of the parotid gland stones are radio-opaque.
False.
Correct.
Mucoepidermoid carcinoma is the commonest malignant tumor involving submandibular, sublingual and minor salivary gland.
True.
Incorrect.
External laryngosele comes out of the larynx through the thyroid membrane.
True.
Correct.
Anterethmoidal nerve is a branch of first division of the trigeminal nerve, V1.
True.
Correct.
Bitemporal hemianopia describes the ocular defect leads to impaired peripheral vision in outer temporal halves of the visual field of each eye.
True.
Correct.
Correct.
8. So you have 8 correct answers and 2 incorrect answers.
So if you calculate, great, congratulations. So let us, you correct. Meantime, I'll just go through the answer. Bitemporal hemianopia, we all know its commonest region. It's pressure on which part? Optic chiasm at the center. So where the fiber decussates to the peripheral temporal region, they are affected. So bitemporal hemianopia because of the central compression. Anterethmoidal is a branch of which branch? I never heard anterethmoidal is anterethmoidal is a branch of V1. And the continuation of anterethmoidal is known as anybody? Yes, external nasal nerve. Sunil, tu bhi le le yaar. External laryngosele comes out of the larynx through the thyroid membrane. It is correct. Mucoepidermoid carcinoma is the commonest malignant tumor involving submandibular, sublingual and minor. I didn't expect this wrong answer from you. Mucoepidermoid is commonest in the parotid. That is a gland which secretes different secretions. Submandibular, which is the commonest malignancy in all these three glands. Submandibular, sublingual and minor. Which one? Anybody? All these three, which is the commonest malignancy in minor salivary, submandibular and sublingual? Yes, correct answer I heard. Adenoid cystic carcinoma. Yes. My job is to confuse you. Don't get confused. And majority of the parotid gland stents are radiolucent. As in contrast to alveolar variety has a worse prognosis. Stones in water and dust cannot occur after complete submandibular gland excision. Why it is not correct? When you remove the submandibular gland completely, how will the stone, can the stone form?
The sublingual gland is connected with the duct.
Yes.
The duct of venous opens.
You know, we should have played the quiz.
Of the mouth around which the water and also it's anti-gravity. So it is anti-gravity.
Part of the duct also, and there are some glands in the duct itself. So the sublingual salivary glands, they actually their secretions go into the water stuff.
Yes, that's what she is saying. So sublingual duct gland on both sides have some duct which open in the water duct. In spite of you have removed the submandibular gland, those ducts known as Bartholin's duct open in the water duct and can lead to stone formation. In spite of having a complete submandibular gland excision done. Aoicon is a landmark where? Anybody? Aoicon? No?
It is there.
Anybody?
It is there.
Come on.
Not in nose.
Aoicon is a landmark for? Where's the Aoicon?
Base of
Come on.
Base of column. Base of column.
Where is Aoicon? Aoicon is here at the occipital brittle glands on both sides where they meet in the midline. That is Aoicon. Mucoid accepted hyphae, yes, correct. SP11 and 6 are predominant etiological factor for recurrent. Out of these 6 and 11, both are responsible for respiratory population. Which one is responsible for more virulent infection? Give very specific answer. 6 or 11, both are responsible for RRP. Which one is more virulent? The guy who will give wrong answer will give the chocolate to the guy who gives Come on. 11. You get double. So 11 is responsible for more virulent infection. So thank you very much for your support. Now the Anjali will announce the results. 4, 3, 2, 1.
Just before we announce it, can we have a huge round of applause for our Toastmaster? I have to say, I feel very sorry for you guys because you're not just dealing with a supreme ENT surgeon here. Thank God he doesn't do any rhinoplasty, but otherwise he does everything else. But he's a radiologist, he's a neurologist, he's a neurosurgeon, he's absolutely everything head and neck you could imagine. And to be taught by him and to be quizzed by him, I think should be an honor, a privilege for you all. It's amazing. I've learned. I've learned things which I'd never even heard. From somebody who doesn't know an IP1 to whatever a T3 new malignancy is, I don't do any of this stuff anymore. I've learned so much. So Dr. Satish Jain, he is a supremo of our specialty, and you should acknowledge him as such.
Big boss. So now Anjali will announce the results.
So, on fourth position, with scores 67.5, Team B.
Team B. Fourth. They did very well. They were in the race. One or two right answers could have taken them into the stream.
On third position, with 70 marks, Team C.
Team C was doing, they were on the top in the beginning.
Then on the second position, with 75 marks, Team A. Congratulations.
Well done. My prediction was Team A. Honestly, my prediction that Team A will win. They were giving amazing answers.
And the winner for today's quiz, Team D with 87.5 marks. Congratulations.
They were behind at times and they recovered in the end like anything. Champions. That's how, that same thing happens in the cricket as well. You're running behind and all of a sudden some hitter comes and you win the match. So congratulations. Your name?
Dr. Avinav Gupta. Avinav Gupta.
From which college?
Sir, from Maulana Azad Medical College.
Congratulations.
Dr. Mandata Sharma from MC, Delhi.
Super, super. Your faculty members, can you name few?
Sir, Dr. Ravi Meher, Dr. Ishwar Singh, sir.
Ravi Meher and Ishwar Singh. So congratulations to all of you. Super duper performance. They were running behind at times and they recovered like anything. So big congratulations, and they win. Both of them win separately the Apple Watch from the organizing team of Aoicon. So congratulations. And Dr. Tarun Oza will provide you. I gave you the contact. And the runners up, you will get your registration amount back. That will be waived off. So congratulations. But you did really well, and I was expecting you to win at one time. So 8 books are going to be given to all of you. 4 from Dr. Madhuri Mehta and 4 from Dr. Narayan Jaishankar. So this is my responsibility to provide you. Sandeep, take all of them. Number, Arjun, take their number, address and post. Okay? Thank you very much, and big thanks to our jury for sparing his valuable time being with us in spite of being so tired for last so many days. Thank you boss.
Thank you,
Thank you very much. Thank you all for your involvement, your support. Yes. Last minute.
We need to give them the.
Doctor Abhinav. These guys know so well.
Unbelievable.
And their understanding is too good, really too good. So congratulations, keep it up. So now you give to Dr. Shafat Ahmed. Congratulations. And Dr. Mansi Sharma. So you are from Maulana Azad, same. So fight within the department, and ultimately the guys come together. Thank you, and once again big thanks to the